Forum of the Euro-Mediterranean PRM School Heimring of Syracuse. And we will start with some welcome messages from the Italian and European bodies involved in this initiative. I am Paolo Boldrini, General Secretary of the European Society of Physical Rehabilitation Medicine and the past President of the Italian Society of Physical and Rehabilitation Medicine. On behalf of the President of the Italian Society, Professor Pietro Fiore, and the President of the European Society of Physical and Rehabilitation Medicine, Nicolas Christodoulou, I wish to thank Franco Cirillo for his effort in organizing this event. We are sure that it will be appreciated, and we are sure that despite the difficulties we are facing because of the pandemic, it will be a very important opportunity for sharing knowledge and for improving our professional activity. So a very welcome, a warm welcome to everyone, to the participants, and again, a great big thank you to Franco Cirillo. Now, Maria Gabriella Ceravolo will address a message on behalf of the E.M.R.S.S board. Please, Maria Gabriella, the floor is yours. Is Maria Gabriella connected? No, we will go to the next message, Mauro Zampolini, on behalf of the PRM E.M.R.S.S. Please, Mauro.
Thank you, thank you. I am very pleased to send a message to this edition of the school, thanking Franco Cirillo, because he really wanted to go on with this edition, this remote edition. Usually we appreciate the Syracuse seaside and the warm welcome from Franco. Usually we can socialize together with the students, but in this case we are far away. And however, we are very proud to support the school as a president of E.M.R.S.S PRM. We think that it's very, very important, the educational part, because inside our organization we have also the board. The past president is Maria Gabriella Ceravolo, that will be with us in a few minutes, and our strategy is to push toward the strong education policy that is very important to support the specialization of physical rehabilitation medicine. So thank you very much, because this is a very important edition. It's a remote edition, but it's very, very important to support and to go on with the Syracuse Mediterranean School.
Thank you, Mauro. Now I will have a message from Milica Lazovic as president of the Mediterranean Forum of the PRM. Please, Milica.
Dear colleagues, dear friends, dear participation of 15 Euro-Mediterranean Rehabilitation Summer School webinar course. Dear Franco, it is my special pleasure to greet you as the President of Mediterranean Forum of Physical and Rehabilitation Medicine, and to wish you successful work in these difficult times. The Mediterranean Forum of PRM promotes education in PRM, a stretching exchange between Mediterranean PRM physicians. The Mediterranean Forum is created to support and help stretching existing a new project that brings together PRM from all the Mediterranean region. I must express my regret that young colleagues, school participants, don't have the opportunity to face-to-face participate in the work of the school and to socialize with each other and to experience the beauty of Syracuse and the wall of Sicilia. Generation of young doctors have had the opportunity to experience it all. but I hope that in the years to come, everything will be as before, and that is will all be just in Angel Dream. Finally, I would like to greet you once again and invite you to attend the 14th Mediterranean Congress of Physical and Rehabilitation Medicine to be held on 13th to 16th October 2021 in Amman, Jordan. See you in Amman, Jordan in October next year. Thank you.
Thank you very much, Milica. We got a message from Maria Gabriella Ceravolo. She will join us later because now she is engaged at the university. So we can go further with a welcome message from Franco Cirillo. I think we have a video to launch. Please, I ask you to present the video. Thank you. Okay.
Paolo?
Thank you, Franco.
Sì,
Yes, please.
Okay. Good afternoon, everyone, and thank you for your participation. I hope next year to meet you in Syracuse. I am pleased to let you know that we have 5,000 participants to attend the course. Good afternoon.
Thank you very much, Franco. And I regret more and more that to have missed the opportunity to join you in Syracuse after seeing those images. But anyway, we hope that in the next year we will be able to be together again. So just let me give you some short information. The session will last up to 8:40 tonight, and each presentation will last about 20 minutes. The participants can ask questions by using the chat in the YouTube channel. Questions will be collected in a repository, and we will try to give reply to questions whenever, if possible, in the next days after the conference. So the questions will not be allowed just after each speech. If Franco agrees, we can start with the session. I don't know if okay, Massimo Barano is ready. Yes. The first speaker is Massimo Marano, head of the Movement and Disorders Clinic of the University Campus Biomedico in Rome, Italy. His presentation will have the title of Movement Disorders, Dystonia, Chorea, etc., Managing the Pharmacological Treatment. Thank you for joining us, Massimo. The floor is yours. We can't hear you. Okay, please open the microphone, Massimo. Not yet.
Okay. Can you hear me now?
Okay, fine.
Oh, great, perfect. Thank you, Professor Boldrini, and hello, everyone. I'm very proud to start this session for several reasons. Also because we are going to talk of a topic that is very close to me, and for the first time, a session about movement disorder doesn't start with Parkinson's disease. And it's something new for movement disorder specialists. And this is by the chance, because at the beginning it was the talk of Professor Ceravolo starting with Parkinson's disease, but I will try to start with something that is not Parkinson's disease, something other than Parkinson's disease. And it's a group of movement disorder that we are going collectively to introduce them as hyperkinetic movement disorders. But they are really other movement disorders. Let's have a look to some statistics. And here there is a statistic from the Baylor College of Seattle, that is one of the most important movement disorder clinics all around the world. And we see that according to their almost 40,000 diagnoses, that 31% of medical problems in the field of movement disorders are Parkinsonism and Parkinson's disease. But half of them almost are hyperkinesias, involving dystonia, non-Parkinson's disease tremors, tics and Tourette, ballism, athetosis, chorea, myoclonus, and other uncommon causes, in this 20% with other uncommon disturbances. And going through this topic, we will talk about the pharmacological therapies around these couple of words, we know that Parkinson's disease and the motor part of Parkinson's disease is mostly dominated on the dopaminergic therapy. In the world of hyperkinetic movement disorders, we have a bunch of therapies that the most important, most known pharmacological therapies are the botulinum neurotoxin, the dopamine depletors, and some kind of neuroleptics and antiepileptic drugs, and the DBS surgery, the deep brain stimulation. We will start to talk about the clinic and the therapy of hyperkinetic movement disorders through a case-based approach. I mean, we will see several cases and several videos on diseases, and I will try to explain you my experience more than give you guidelines or a general point of view. And we will start with dystonia, paroxysmal movement disorder, and their treatment. Is characterized by abnormal movements or postures that are caused by sustained or intermittent muscle contractions. Here we have a case of generalized dystonia. It was a patient that had a kernicterus after the birth, and he developed since 3-4 years of age. Generalized dystonia is an isolated dystonia. It means that it has only dystonic features, maybe some distal atetosis, but it's mainly dystonia of the trunk, of the neck, of the limbs. We classify dystonia according to clinical axis of the clinical features with either age at onset, body distribution, temporal patterns, associated features, and other occurrences of neurological systemic disease, and according to the etiology. This is something that we will find all over the presentation. Going on with the dystonia and going through the therapy of dystonia, dystonia is caused by something that is not going on well in the neurotransmission. This is something that is not always structural. And there are 3 neurotransmitter problems here that relates to the cholinergic system of interneurons that involves the dopamine transmission and the dopamine transmission of the nerve terminals and the medium spinal neuron that are GABAergic neurons. And to treat dystonia, we should use the antidystonic treatment that mainly relies on the botulinum toxin therapy and oral drugs that we are going to see. Use of adjuvant drugs that we will see case by case. And we should not forget that physiotherapy in the world of dystonia is of main importance. And there are very few centers that are able to perform physiotherapy in an appropriate way. But this is off topic regarding my presentation. And when we talk about therapy, we know the botulinum toxin is injected, and this is particularly useful for focal more than generalized dystonia, and more for isolated than combined. When we talk about combined, we talk about, for example, dystonia plus myoclonus, dystonia plus Parkinsonism, or dystonia plus tremor, where botulinum toxin is less effective than isolated form. Anticholinergic drugs that are particularly useful in young people more than older, mainly because of the side effects of the drug, and more commonly used in generalized dystonia, like the video we saw before. And other drugs, like analgesics, especially useful in neck dystonia, anxiolytics, and depressor, beta blockers, used when there is a combined dystonia with tremor, baclofen for generalized dystonia. And don't forget the levodopa trial, because there is a class of dystonia, this is the dopa responsive dystonia, that could benefit by the levodopa trial. And these are younger patients with axial dystonia and generalized multifocal form. Talking about botulinum neurotoxin, we know there are 7 distinct subtypes, but going at the functionality of this molecule go into the nerve terminal, dissociate the light chain by the heavy chain, and the light chain is going to perform a cleavage of some proteins that helps the cholinergic vesicle to fuse with the membrane and to go into the neuromuscular junction. So it inhibits essentially the muscular contraction. We have several types, but we are not going through these, and we will talk also about why it works. It works not only through the effect of the muscle relaxation, but it works through the effect that has on the intrafusal and on extrafusal fiber of the muscles. botulinum toxin helps to relax the muscle, but also to give proprioceptive afferents to the central nervous systems, also because the interfusial fiber that is characterized by a proprioceptor works always in parallel with extrafusal muscle fibers, thanks to the gamma motor neuron activity that is in parallel with the alpha motor neuron activity. The activity of the muscle spindles and is altered in dystonia, and dystonic patient though has also an altered coupling between the activity of the sensory and the motor cortex. And we see that here with a neurophysiological study of the motor cortex in neck dystonia patients, the use of botulinum toxin can, at 1 month after Botox injection, alterate the PAS, that is a measurement of sensory motor plasticity, and going to the basal, almost to the basal, after 3 months after the injection. We know that botulinum toxin had a length of 3 to 6 months of efficacy. Let's go to some clinical cases. Here is a case of neck dystonia with a left lateral caput, a left torticollis, and a left retrocaput. It is not painful at the beginning, but patient could develop osteoarthritic problems and so secondary pain. In the second video, we can see another lady with a left torticollis. This is a classical form, why here there are more muscles involved, and now we are going to talk about that. And these first 2 cases are isolated neck dystonia, some focal forms. This third case, sorry for that, this third case is a young lady with a right torticollis and dystonic tremor. This is challenging, and the patient going through several interventions that we are going to see in a while, other than botulinum toxin. Here you can see that the lady touched her nose. This is one hallmark of the dystonia clinical presentation. The name is sensory trick. The patient, without forcing himself to perform the movement, give a sensory afference to the movement of the neck. And the last case is another formal isolated dystonia with left torticollis and left lateral shift and lateral caput. And let's go to the treatment. The first one at the Botox, the second one at the xenomine, that is another kind of botulinum toxin type A. And sometimes when we face with the first molecule, we use the second because in particular the xenomine has less proteins that could help in the generation of some antibodies that goes to block the efficacy of the toxin. In the third case, we had the left sternocleidos denervation. It was an old intervention without a great benefit, and she has Botox, and as we said before, she used the propranolol 40 milligrams a day to provide benefit with the dystonic tremor of the neck. The last patient had also anticholinergic drugs, 4 milligrams 3 times a day, that helps in modulating the neck contraction. This is the way we can inject Botox with the here with the ultrasound guidance, and we see that in this patient we are going to inject the sternocleidos on the right. It is a superficial layer muscle. The left splenius that is deep with respect to the trapezius here, and the left semispinalis that is the third layer muscle here in the neck. And here ultrasounds are quite useful and quite important to go through the layers of muscles. Generally, we use ultrasounds coupled with EMG guidance or both. Other kinds of dystonia are the writer's cramp. Here we can see a classical writer's cramp that is an adult onset specific upper limb isolated focal dystonia. It's idiopathic. We can see how the patient forced to flex the wrist while writing, and there's some compensatory movements here in the upper part of the arm. And in the second video, we're going to see a typer dystonia. She has also a writer dystonia, also a writer's cramp, but when she works in typing. She has a tremor of the second finger of the right hand that try to extend. And she works with typing, so it's quite invalidating for her. And in the third case, we have a musician dystonia, he's a drummer dystonia, with involuntary flexion of the wrist here. And he's a professional drummer, so it's quite invalidating for him. The treatment choice in all three cases is the botulinum toxin, because it's particularly effective in focal isolated dystonia, as in these three cases. Here is an example how to inject in the muscle of the drummer. For example, here we can see the projection of the ultrasound in the flexor carpi ulnaris. But this is not to show you how to inject, but to talk about dosages. In this small kind of muscles, the dosage to start is 5 to 10 units, and we should be particularly careful in extensors, because extensor requires half the dosages of flexors. The side effects is the weakness, as you know. Other kind of dystonia is here we have blepharospasm. We can go directly to here. We can see the patient that try to speak and read, and with a forced closure of the eyelids. And the treatment choice is the Botox, the botulinum neurotoxin. And now we are going to see how. The second case is a very complicated case of Mesh syndrome. There is an evolution. We can see a complication of the blepharospasm. We can go through the video in the last part where she has these overflow movements of the neck. That is another feature of dystonia. This is blepharospasm or mandibular dystonia and neck dystonia. The name is Mesh syndrome. She used also clonazepam, this is a benzodiazepine, and the speech and language therapist. And the last part is, I don't know if you can hear the sound. This is a spasmodic dysphonia. It's a kind of focal laryngeal dystonia with forced closure of the vocal cords. Sorry for that again. And we can go to treatments. Here is an old video by myself trying to starting having Botox in the face. And now we are quicker in performing this kind of injection. And we can inject the orbiculary oculi bilaterally with 1.25 to 2.5 unit of botulinum toxin type A Botox or Xiumin. It's quite easy to perform and is quite effective. The side effects is the weakness, so the eyelid opening. Going again, and this in the case that we saw, this is the treatment of that lady with the spasmodic dysphonia. We have first an injection with lidocaine that inhibits the gag reflex, and then we go through with EMG and also with fiber optic control performed by the ENT specialist. And we are going to treat, sorry for that, we're going to treat the thyroarytenoid muscles that provokes the spasm in adduction. And I don't know if you can hear me.
Oggi è una bella giornata di sole. Oggi è una bella giornata di sole.
Italian. And this is the voice after the treatment.
Oggi è una bella giornata di sole.
And more easy for the lady to talk, but it's just a little bit whispered. That is a main side effect of the botulinum neurotoxin here. We change and we go to young onset acute progressive multifocal dystonia. This is a case of dystonia.
Così? Mani avanti come hai messo prima, così?
This is a grimace, the dystonic grimacing with the dystonic carpal spasm, and this was provoked by metoclopramide, that is an antiemetic drug. And after the infusion of biperidine, 5 milligrams, she recovered fully in a while up to the basal. Okay. Another case that is very interesting is a young onset paroxysmal multifocal dystonia of a professional runner. after the abrupt septum movement, like the sprint, he develops a very tricky contraction of the left part of the body, mainly on the hand and of the quadriceps. We can see him in with quite a normal neurological examination, and after the abrupt septum movement, he developed this kind of problem in the left hand, as you can see. It's not good for a professional runner having this because could affect the performances, both hands. It is treated with the sodium channel blockers with carbamazepine, a very low dose, 200 milligrams daily. Again, another kind of this kind of dystonia, a lesional dystonia, structural dystonia, caused by the lesion in the probably in the subthalamic thalamic tract of white matter. Is a patient with multiple sclerosis. After hyperventilation, prolonged hyperventilation, is going to present spasm, non-epileptic spasms in the right part of the body. He had the spontaneous remission after a while, some months. Again, we're going to see some example of chorea in Huntington and Huntington-like disease. I have some few minutes, and we know that the mainstream treatment of chorea is tetrabenazine that has side effects like depression. So in a disease that is Huntington disease and Huntington-like disease that could induce depression, please avoid to start with tetrabenazine without evaluating the degree of the chorea, if this is invalidating or not, and if patient has depression, psychosis, aggression, because in this case, is better using the typical neuroleptics more than tetrabenazine, because this kind of drug could induce depression and suicide ideation. This is a case of a spinocerebellar ataxia 17 with an invalidating chorea of lower limbs. This is not to show you how he's moving the feet involuntarily, this is a kind of chorea, but how, in case of psychiatric part, so depression and suicide in story, the treatment could be challenging. He has olanzapine, a mood stabilizer with valproic acid, benzodiazepine for anxiety, and venlafaxine as antidepressant, no tetrabenazine here. While in a case of a one with mild chorea without psychiatric counterpart, but chorea was invalidating with expression of the face and movements, with a ceruloplasminemia that is a mimicker of Huntington disease too. With the tetrabenazine, she's more able to control movements. She had less degree of ataxia, because she's able to control better the upper limbs. In this case, with obsessive thoughts, suicidalization, rigidity, tremor, and bradykinesia, and myoclonus, and dystonia, is a case of general Huntington disease. Treated and well compensated, sorry for that again, with olanzapine, benzodiazepine, and antidepressant. Very invalidating, but it's not responsive to any other kind of treatment, especially when suicidalization is there, because tetrabenazine could be risky for a young lady like that. You can see myoclonus, you can see chorea of the trunk, upper limb, and the face. You can see dystonic cramp here in writing. We can go to other kind of, maybe I have some more time, of tardive dyskinesias. You my experience, it is related to dosage load of antipsychotics, the time of the exposure, and is particularly related to atypical antipsychotics. But attention, because the abrupt interruption of antipsychotics and neuroleptics could lead to dyskinesias, in particularly to chorea, copulatory dyskinesia, the dyskinesia of the lower part of the trunk, and akathisia. This old lady has a dystonic posture of the neck and akathisia and a chorea of lower limbs, so strong that she could not walk. But with a low dose of tetrabenazine, was able to get back walking with assistance, and she for sure required some rehabilitation here. You can see here that these kinesias are less prominent. She's quite happy to standing. Okay, we can go to the myoclonus. We have here the generative myoclonus. The name is polymini myoclonus. It is observed in MSA, not need to treat. And this is a case of post-epoxy chronic myoclonus, the Lansat syndrome. She had a cardiac arrest. While 500 milligrams times. Then we can go through these. That is a kind of a segmental myoclonus, probably spinal myoclonus. You can see that this foot tried to bounce in the floor, and the limbs began to be stiff. And this is a case of stiff limb syndrome, but this is in the stiff person's syndrome spectrum disorder. This is treated mainly with benzodiazepine and steroids. She's able to walk, but with the disease going on, she developed this kind of stiffness that is difficult to understand as a semiology and phenomenology. She needs to have someone with hand to walk, and the name of this disturbance is a psychiatric counterpart of the disease. The name is pseudo-agoraphobia. And we're going to finish with tremor and tremor-like condition. This is a case of essential tremor in writing, and this is a rare form of dystonic tremor, and the name is primary tremor of the writing. She has this tremor just while she is writing. Treatment is tricky because all these drugs, treatment of essential tremor has a lot of side effects, especially sedation, cardiac side effects. And in this field, we found some space for deep brain stimulation. In this case, the VIM deep brain stimulation, and you can see here before the titration of the stimulation, before the regulation, and here after the regulation of the stimulation in a case of essential tremor. This was the patient of before. But now we have new technology with ultrasound focused lesion that could try to simulate the effect of deep brain stimulation and provoke clinical effect similar like that. And again, to finish, we have some tics and Tourette syndrome. If I have some more time, but I think I'm a little bit long. And we have a case of Tourette syndrome and tics. And this patient went at the deep brain stimulation too. And we can see here, after the simulation, here before, not having it film. And this is the therapy before the stimulation, the therapy after the stimulation. Before the stimulation, we had a bit of cannabis and alcohol, a lot of clonidine, citalopram, alloperidol, and he lowered significantly the dose after the stimulation. The Tourette syndrome is a complex disease with a lot of psychiatric counterpart, like many other hyperkinetic movement disorders, and mainly characterized by chronic. And this is something about this stimulation, and this is how the tic decreased in 3 years observation. I know him now at 5 years of follow-up. But the deep brain stimulation is not able to treat what is the psychiatric counterpart of the disease, that is paranoid ideation that is a high level along the disease course. Okay, this is all. Thank you for your attention. Maybe I had a run, but I hope you enjoy my presentation. And if you have questions, we will be more than happy to answer in the session of answering questions. Thank you.
Thank you very much to Professor Marano. Thank you very much. We will see if someone will send questions for you, and we will try to send the questions to see if we will be able to give answers afterwards. Now I can introduce now Professor Maria Gabriella Ceravolo. She joined us now. She is a full professor of physical rehabilitation medicine in the Department of Medicina Sperimentale and Clinica of the University Politecnico delle Marche and in Italy, and she also is the president of the E.M.R.S.S board. So I kindly ask Gabriella if she wants to give us a short welcome address on behalf of the E.M.R.S.S board. Please, Gabriella,
yes,
the floor is yours.
Thank you very much. I'm trying now to share my screen. Hopefully I will be successful. Please tell me if you are looking now at what... Yes, okay. Thank you. Okay. Thank you again. And I wish to congratulate Professor Franco Cirillo for this, that is the 15th edition of the Euro-Mediterranean Rehabilitation Summer School. We should have celebrated these important appointments last year, but we are more than happy to celebrate it today, because even if we are experiencing a different setting and an online webinar, in any case, we know that a lot of people are listening to us more than would have been possible in presence. So in any case, this adaptation has given a positive outcome. It is very important to have these periodic appointments that gathers PRM trainees from different European countries and from Italy too. The European body that I represent here, that is one of the oldest one in physical medicine rehabilitation, that is the European Board of Physical and Rehabilitation Medicine, has always supported this kind of educational events, as well as other European schools like the European School Marseille, and recently the Robotic Rehabilitation Summer School. So again, congratulations to Professor Franco Cirillo, to all the speakers, to the scientific and organizing committee for maintaining this appointment through years, and mainly for choosing this topic this year that attracts a lot the interest of PRM trainees. I appreciated a lot the presentation by Professor Marano that was so full of very interesting clinical cases and videos. I regret I will not be as as interesting in my presentation, because Parkinson's disease, and I will talk about the management of the pharmacological treatment, I assume that is a clinical condition very well known by people, and would have been a little bit trivial to present the clinical features of this condition. Moreover, concerning the pharmacological treatment, the main message that I wish to convey will be will concern not only the positive effects of the treatment, but as you will understand and will learn listening to me, what the drug treatment cannot ensure to people with Parkinson's disease. So I will start with these different questions that concern our perspective when prescribing treatment to people with Parkinson's disease, or when managing people with Parkinson's disease who are already under treatment. Why should we start treatment? When? What drug or drug combination should we choose? And how long should treatment last? And the first question, I believe that should receive an answer by David Sackett. You can easily recognize David Sackett and his approach to evidence-based medicine, TRIAD. Of course, we integrate the best external evidence with the individual clinical expertise, but especially in case of people with chronic conditions like Parkinson's disease, we must take into account patient values and expectation. So what we know is that drug treatment is used in this condition to reduce the burden of disease in terms of symptom severity. But again, even if we are all convinced of the miraculous effect of drug treatment on the cardinal symptoms of the disease that are tremor, bradykinesia, akinesia, and also on one non-motor symptom as fatigue, we should always take in mind that other symptoms that are really disabling, like trunk posture abnormalities, depression, anxiety, pain, sleep disorders, may behave in a variable manner, because sometimes they can be improved, but at some other times in other people they can be worsened by drug treatment. And other very important and disabling features like gait, balance disorders, speech disorders, that is to say the so-called axial features of the disease, and non-motor symptoms like bladder incontinence and constipation are usually resistant to levodopa and dopaminergic agents, whereas psychosis and hallucinations that depend on the disease but can also be enhanced by dopaminergic medications as side effects. So we must take in mind that drug treatment has not only the goal, must not only reach the goal of reducing the burden in terms of symptom severity, though mainly in terms of disability severity, prevent disease progression, reduce the number of complications, that is mortality risk and hospitalization. And it's easy to understand that the traditional symptomatic treatment for Parkinson's disease, levodopa, dopaminergic agents, and so on, usually do not address these other goals, so that disability is ever growing over time in spite of an effective motor symptom controls. And it is not a surprise that the disability adjusted life years computed over a period of around 23 years by the Global Burden of Disease study in 2013 has significantly increased. So the burden of disease overall in a worldwide perspective is increasing more and more. That Parkinson's disease affects independence in daily living is very easily demonstrated also by this observational study that compares the amount of people who lose independence at 5 years of diagnosis with respect to age-matched healthy controls. Of course, the progression of disease is conditioned by different individual variables like higher age at onset, symptom duration, presence of mild cognitive impairment, and what is more, the phenotype of the disease, with the tremor dominant phenotype behaving in a better way than posture impairment gait disorder phenotype. So it is not a surprise that the patient satisfaction with the drug treatment, with the traditional drug treatment of the disease is low. This is the results from a Swedish survey addressing patient satisfaction with drugs and demonstrating that a very low proportion of patients declares to be very satisfied or satisfied with drug treatment based on a few considerations like this one. The first one is the most important to my opinion. Available agents neither cure the disease nor slow its progression. So this is the outcome of a treatment being mainly symptomatic, and on the fact that several side effects can be troublesome, especially those connected with dopamine agonists. Moreover, the way by which individual patients perceive the symptoms and the burden of disease is very variable. So shaking, rest tremor may be very bothersome to one individual, but not to others. And also cognitive, psychological, behavioral features affect more the family members than the patient. So what is most important is that the clinician should take decisions about the prescription of drugs based not only on what they see, that is the motor symptoms of the disease, but also on other troublesome symptoms that sometimes are not conveyed directly by the patients. And some of these are depression, some others are hallucinations, delusions, and so on. Being a specialist in physical medicine rehabilitation gives us a more deep perspective of what means considering patients in a holistic way, and also to understand that activity limitations and participation restrictions in patients with Parkinson's disease are affected not only by some function impairments like, of course, motor problem, locomotion dysfunction, bradykinesia, and so on, but as you can see here in this study published in 2016, by depression. Depression, among all the body function impairment, behaves like the variables that mostly accounts for the variation in mobility limitation and problems in psychosocial functioning, together with the living environment and the individual attitude. So again, in prescribing drugs, we should take into account the whole condition of the patients. Concerning the specific prescription of anti-Parkinsonian drugs, we can refer to the most recent guidelines by NICE, published in 2017, that indicate as first-line treatment levodopa. Levodopa should be offered to people in the early stage of Parkinson's disease when motor symptoms are considered as a factor impacting their quality of life. Alternatively, when symptoms do not impact the quality of life of people, so are mild, it is possible also to consider a choice of dopamine agonists, levodopa, or inhibitors of monoamine oxidase B in the early stage, whereas, as all of us already know, it is not recommended to offer ergot-derived dopamine agonists due to side effects. This table compares the effects of levodopa with respect to dopamine agonists and inhibitors of monoamine oxidase B. It is easy to understand that levodopa is the most powerful drug at treating motor symptoms because it allows for the greatest improvement in motor symptoms compared to the other agents, the greatest improvement in activities of daily living, but also, unfortunately, it exposes people to a greater risk for dyskinesias compared to the other agents, but to a fewer specified adverse events, whereas dopamine agonists are most associated with excessive sleepiness, hallucinations, and mainly with impulse control disorders. This is an algorithm that can be very useful to understand how to manage people with Parkinson's disease using drugs from the early phase to the advanced phase. So in those people who show slight symptoms, it is possible to start with monoamine oxidase B inhibitor. In presence of functional disability, we can either choose levodopa, titrating it up to 400 milligrams per day, or dopamine agonists in case patients is younger than 70 or 75 years. In the steady state, we must distinguish between the older group and the younger group, taking in mind that dopamine agonists carry on a greater risk of side effects, especially of cognitive effects and behavioral effects in people older than 70, 75 years. So we can prescribe a combination therapy, but with care about possible development of impulse control disorders, and in the advanced phase characterized mainly by motor complications, we must adopt an integrated schedule, including also COMT inhibitor, including amantadine to treat disabling dyskinesias. And when the motor complications become uncontrollable with any drug schedule, we also can consider device-aided therapy, or what is called non-oral drug therapy. So this table also helps me to compare the effects and side events induced by dopamine agonists and other agents in the advanced phase. As you can see here, apart from amantadine, all these agents allow for an improvement in motor symptoms and in activities of daily living, reduce off-time prevalence, but also carry an intermediate or a higher risk for adverse events. So, especially when hallucinations are concerned. Of course, the last recommendation is that of do not offer anticholinergics to people with Parkinson's disease who have developed dyskinesia and motor fluctuations due to a greater amount of side effects. Concerning the care for possible side effects arising in people treated with dopaminergic agents, we must be very careful at counseling people and family members about the risk of impulse control disorders, and also selecting in an adequate manner people who receive dopamine agonists, because some subgroups are at greater risk, like people who use alcohol or who were already carrying impulsive disorder before the development of Parkinson's disease. Excessive sleepiness, sudden onset of sleep is also frequent with dopamine agonists, as well as hallucinations and delusions. Concerning sleep disorders, we must monitor people taking anti-Parkinsonian drugs, and also check for daytime sleepiness, REM sleep behavior disorders, and nocturnal echinacea. In this case, especially in this last case, we can prescribe in an increased dosage of levodopa or of oral dopamine agonists in order to reduce nocturnal echinacea. Especially rotigotine, in a study that was conducted in collaboration with our Center for Movement Disorders, was shown to exert a positive effect on sleep disorder while reducing the limitation in activities of daily living. Concerning the treatment of hallucinations that can be a consequence of the degenerative disease, or also a side effect of treatment, we must take in mind that hallucination must be treated only when they are not anymore tolerated by the patient and by other family members. The first step is to reduce the dosage of any Parkinson's disease drug that might have triggered hallucinations. And as a second step, we could use a typical antipsychotics like quetiapine as first line, or clozapine as an alternative. Both these drugs do not exert an anti-Parkinsonian a Parkinsonian effect, so they can be used very easily in this kind of patients. Considering dementia, we can offer cholinesterase inhibitor for people with mild or moderate Parkinson's disease dementia. And also as an alternative, as a second-line drug, memantine, only in case cholinesterase inhibitors are not anymore tolerated or are contraindicated. A few words must be spent considering non-oral treatment in people with Parkinson's disease. Non-oral treatment has a potential benefits because it allows to bypass the limits of oral administration, like swallowing difficulties, delayed gastric emptying, and mainly the competition for absorption in the gut of levodopa by protein. In this study, two specific non-oral treatments were considered, not only with respect to their efficacy, because both are very effective in treating motor symptoms. The first one is subcutaneous apomorphine infusion that is shown in this picture. But mainly with concern about side effects. And here you can see that this kind of non-oral treatment is penalized by 35% possible side effects in the population receiving this kind of approach. There are both administration or device-related complications and apomorphine-related complications that are very variable in their prevalence, but also show a very high rate. And the other non-oral treatment is the administration of duodopa, levodopa, carbidopa intestinal gel infusion directly in the jejunum through this PEG-PEGI device. Again, this is an Italian study on around 1,000 people, showing the rate of side events that can be expected in people receiving this very effective treatment on motor symptoms, but also a treatment that should be balanced concerning the benefit with the risks. And the risks concern one patient out of 4, around 20 related, device related, infusion related of the treatment, as well as other possible drawbacks like the worsening of cognitive decline and the poor compliance of caregiver to be taken into account. I would spend a few words on the possible pharmacological treatment of non-motor symptoms. I told you in the start of my presentation that non-motor symptoms are usually not respondent to levodopa or dopaminergic agents, and this is true, but this does not mean that they cannot be treated with pharmacological agents. Here you can see orthostatic hypotension, cialorrhea, constipation. For each one of these different non-motor symptoms that are very frequent in people with Parkinson's disease, there is a series of drug agents that can be used, like vasoactive agents for orthostasis, anticholinergics for cialorrhea, laxatives or serotoninergic agents, or even dopaminergic agents for constipation and so on. But considering our specialty, physical medicine and rehabilitation, I would show you that botulinum toxin injection is especially effective for the treatment of sialorrhea, as well as of constipation, as well as of bladder hyperactivity with an increase in urinary frequency and urgency. So there are some reports in the scientific literature showing that Xeomin, Botox, and Dysport can be injected in the detrusor and be effective for overactive bladder. Of course, there can be adverse effects linked to the procedure, or especially to the dosage that is injected, with the risk of urinary retention when the dosage is too high, or also urinary tract infections due to urinary retention. There are very rare reports concerning the possibility of treating outlet-type constipation in Parkinson's disease with the injection into puborectalis muscle under ultrasonographic guidance. 60 units of type A botulinum toxin have been injected in this report with benefit. And finally, also in very selected anecdotal case reports, botulinum toxin A has been injected in the pyloric sphincter in different sites in order to reduce gastroparesis that can be particularly disabling in some Parkinsonian patients. I would also show you our experience with the treatment of drooling, that is one of the most disabling symptoms in the advanced phase of disease for people with Parkinson's disease. It is a consequence of dysphagia, of the impairment of swallowing mechanisms. It leads to the accumulation of saliva in the oral, in the mouth, with interference with the language expression, and also becoming an embarrassing symptom through saliva drooling. So the injection of botulinum toxin A, but especially of botulinum toxin type B, has revealed a very effective approach to the treatment of drooling, with an improvement not only in the total saliva production that is reduced based on the assessment of quantitative measures that we have administrating, just weighing the weight of rolls inserted in the mouth and measuring the amount of saliva produced in 1 minute. But it is also effective on some patient-reported outcome, like quality of life and visual analog scale of subjective impression of improvement. So the last area that should be taken into account when we prescribe drug treatment, symptomatic treatment in people with Parkinson's disease, concern the possibility of leading to a neuroprotective effect. And this is what mainly interests people with a neurodegenerative disorder. Unfortunately, to date, recommendations from guidelines are all negative in this context, because the recommendation underline that vitamin E, coenzyme Q10, dopamine agonists, and inhibitors of monoamine oxidase B are not effective at all as neuroprotective agents. It is a pleasure to underline that the only tool, the only therapeutic intervention that has been recognized as having and exerting a neuroprotective effect is exercise in people with neurodegenerative disorders, and especially in people with Parkinson's disease. So I'm going to conclude with these key messages. that are addressed mainly to neurologists more than to specialists in physical medicine and rehabilitation. It underlined the fact that, of course, each patient with Parkinson's disease is different, but mostly that there is more to Parkinson's disease than meets the eye. So we should never base the prescription of drugs and in general the prescription of drug treatment, not only dopaminergic agents, but also other drug treatment, just on motor symptoms, but we should always address levodopa-resistant motor features and non-motor features, and also consider the real disabling impact of motor and non-motor features on patient well-being, so trying to balance benefits and risk of drug treatment based on the impact that each symptom has on the perceived quality of life and well-being by the patient. We must be aware that patients can be dissatisfied with therapy and consider all the financial, social, and cultural aspects that may affect outcomes. So the main key message is that we should always address patients in a holistic way, addressing the physical, psychological, and social aspects of the disease, as the International Classification of Functioning framework invites all care workers to do in any case, for any disease, for any patients suffering from disability. So I thank you for your attention. I hope to have given you some more hints about the treatment of this very disabling disease, and also some aspects to be considered more in your future profession. I'm available to answer your doubts, your questions through the channels that will be made available by the scientific committee and the organizers of this webinar. And again, I wish to thank the organizers for inviting me to this very interesting educational event.
Thank you. Thank you very much, Maria Gabella, for this complete and exhaustive presentation. I must transmit you also the congratulations from Santi Mikhail, who is following us from Greece. Hey,
thank you.
And a warm welcome to Santi too. And now we keep going on the area of the neurodegenerative disorders. We turn to the area of multiple sclerosis. It's a pleasure. Rino, head of the Clinical and Neuroimaging Research Center of the Center Neurolesi Bonino Puleio in Messina, Italy. Thank you for coming, Silvia, and the floor is yours.
Minute to see the presentation.
Okay, there is a background noise. Someone should shut off the
Okay. Good afternoon, and thank you to organization to invite me to very, very interesting webinar. So, multiple sclerosis is a very, very hot topic because MS is considered one of the most common neurological disease for the young people. And okay, what MS is not. So, multiple sclerosis is not contagious and directly inherited, and it is not always very disabling. In fact, people affected with MS have very close to a normalized expectancy. What causes MS? It's probably that a genetic predisposition is very, very strictly correlated to environmental triggers that could cause an immune attack that gives a loss of myelin and never fever. So this pathology is very, very strictly correlated to the strategies of a therapeutic approach in MS. But what happens in MS? These cells release some chemical aspects that really other immune system force, and then attack the myelin, and this attack could cause the MS damage lesion that we see at and right. So the clinical symptoms that we could find in MS are very, very individual and unpredictable. For example, fatigue is one of the most common symptoms in MS patients. Decreased visual acuity, or bladder and or bowel dysfunction, anesthesia, emotional disturbance or cognitive impairment, pain, spasticity, gait, impairment of balance, and tremor. So the diagnosis of MS is essentially a clinical diagnosis, and it is very important to put the attention in the dissemination in the space and in the time. There must be no other explanation. So the MRI is considered the gold standard to perform diagnosis, instrumental diagnosis in MS, but also evoked potential such as visual or somatosensory evoked potential or lumbar puncture are very, very important to help to confirm the MS diagnosis. So there are different patterns or cause of MS. The radiological isolation syndrome is a very, very recently classification, and is considered that some patients have no clinical sign of MS, but a radiological picture very, very suggestive of MS. Then we have the clinical isolated syndrome, and the form, the most common, the relapsing remitting MS, and then the progressive MS. The clinical isolated syndrome is very, very important because it could be considered such as the first neurological episode caused by the myelination in the central nervous system, and it may be monofocal or multifocal, as is important to that may or not may go on become MS. So interferon medication in this case could delay the second episode. Then what happens in MS over the time? We can have the most common form, that is the relapsing remitting course. So relapsing course can be active or inactive, and worsening or not worsening, and then the progressive course can have with or without progression. It is very important for the approach of therapeutic treatment. So it's very important that to date we have a very, very common and very, very most line that we use to treat multiple sclerosis. It is important to focus that MS treatment team is composed not only by the neurologist, but also by urologists, nurses, psychiatrists, physical therapists, speech language pathologists, psychiatrists, pharmacists, and neuropsychologists. So it is very, very important to treat not only the course of disease with some drug that could disease modification, but it's important also to treat the relapse, and it is important also to treat this patient with rehabilitative treatment. So how are relapses treated in MS course? It is very important to treat when the patient has mild or sensory impairment, and we use 3 or 5 day course of prednisolone, or some neurologists use high dose of oral steroids. Well, in this picture we can see that today we have 17 disease-modifying therapies that are FDA approved to treat the form of relapsing of MS. In orange, you can see the subacute administration therapy, so glatiramer acetate, interferon beta 1A and 1B. In blue, you can see the oral administration of multiple sclerosis, dimethyl fumarate, fingolimod, teriflunomide, and cladribine. The orange and the blue underlying therapy are used as first line. The inclusive treatments you can see in gray, and they are alemtuzumab, mitoxantrone, natalizumab, ocrelizumab, or rituximab. So, for example, mitoxantrone is used for the progressing form. Natalizumab is used when the first line are not good, and the rituximab is an off-label for MS, and it is used for neurotic myelitis. So this therapy, what do? These medications do not cure the disease, make people feel better or alleviate symptoms, but it's very, very important to start this therapy as early as possible, because it's probable that they decrease the disease progression. In fact, it is known that MS is strictly correlated to irreversible damage to axons. But when we use this treatment as early, it is possible that the progression and then the neurodegenerative phase of MS could be very late. So, in the future, it is possible that some treatment challenges in MS research could be used. For example, the use of combination of strategies such as anti-inflammatory or neural repair or neuroprotection therapy. And then this is a new treatment on horizon in a very, very experimental phase. For example, potential therapy such as oral estrogens or latinimod, or others such siponimod or masitinib. Then multiple sclerosis has very, very several symptoms, and without that, fatigue is one of the most common symptoms and invalidate symptom of MS patients. So very, very often is easily misunderstood by family members, and is a very, very multifaceted symptom. We use some medication for fatigue, such as amantadine or modafinil, but it's very, very important also to use a rehabilitation treatment to manage MS symptoms. In MS patients, it's very important also to manage bladder dysfunction. In fact, bladder dysfunction is a very, very major cause of morbidity and social isolation for these patients. So it includes urgency, frequency, incontinence, or nocturia. And very important, the use in this case of anticholinergic or anti-muscarinic medication. Also, the managing bowel problems is symptoms such as constipation, it is the most common, or the diarrhea, or the bowel incontinence, it's very important to use also in this case anticholinergic medication. Then the increased muscle tone, especially in the most advanced stage, such as spasticity, is very, very important to treat as early as possible. We can use some oral medication such as baclofen, especially oral and in intrathecal infusion, then tizanidine or clonazepam or gabapentin. And then we can use also the bottle injection, and the rehabilitation treatment is very important also in this case. The managing of the primary sexual dysfunction is very important in MS management because they are very, very young people. So these patients also suffered by reduce of libido, sensory disturbance or anorgasmia for men, and for women, reduce of lubrication. So it's very, very important to use and very, very specific treatment such as anticholinergic, antidepressant, or anti-spasticity meds. And very important also the education and the counseling for these patients. The managing of cognitive dysfunction in MS patients is important because MS involves also white than gray matter in the brain. And then patients affected by MS also have in early stage a picture of brain atrophy. So the cognitive dysfunction is very, very closely correlated with the number of lesions and lesion area on magnetic resonance imaging. So it's important that the disease-modifying therapy could prevent relapse. It is important to use in early stage the cognitive rehabilitation for these patients. And then strictly correlated to cognitive impairment is also the management of depression. In fact, depression is one of the most common symptoms of MS. So we can some therapeutic approach such as SSRI, for example, venlafaxine or citalopram or vortioxetine. It's important also the use of psychotherapy for these patients. Another management important for MS patients is the management of pain. In fact, neuropathic pain is a very, very often present in patients affected by MS. Symptoms such as paroxysmal pain, trigeminal neuralgia, or headache. And we can use anticonvulsivants such as gabapentin or dysesthesias. We can use in this case tricyclics or anticonvulsivant therapy. And then we can have also a secondary nociceptive pain. So in this case, the rehabilitative treatment is the most important treatment for these patients. Then also the management of ataxia and tremor in the advanced stage of MS is very, very important. Then we can use propranolol or primidone, or also the thalamic surgery for tremor, even if in this case generally have a very, very poor result. Just a few minutes to talk about robotic rehabilitation in MS. In fact, it is very important to use with the traditional neurorehabilitation treatment also the use of some accompaniments such as Locomat, is an external exoskeleton, or a cognitive use such as the E.M.R.S.S on Vibratus to, for example, the treatment of dysphagia in the advanced stage. And then, for example, we have in our center another option of the treatment, the current computer-assisted rehabilitation environment it is a very, very important option with patients, especially to treat gait impairment or balance impairment. In fact, Karen is very, very versatile and multisensory system for clinical analysis and rehabilitation. And motor rehabilitation, in this case, is strictly correlated with the cognitive rehabilitation. Then we can conclude that E.M.R.S. is a chronic, unpredictable disease, and to date, the cause is still unknown. And E.M.R.S. is not fatal or always disabling, and it's very important to underline that early diagnosis and treatment are important to decrease the disease progression. So the treatment includes attack management for the relapse, symptom management, disease modification, rehabilitation, and emotional support for patients and their caregivers. So thank you for your attention.
Thank you very much, Silvia, for your presentation. It's a very interesting one. And thank you also for being able to maintain the times scheduled. And now we will turn into acquired brain diseases. The floor will be given to Mauro Zampolini, President of the E.M.R.S. PRM. As you know, probably you know, everyone knows Mauro Zampolini, and he's a director of the Department of Rehabilitation USL Umbria 2 in Italy. So the floor is yours, Mauro. Thank you for joining us. Please open the micro. Thank you.
Okay, thank you, Paolo, for the presentation. I'm going to speak about the traumatic brain injury, which is a field of competence of you. So I like also your comment about this presentation. Of course, the pharmacological treatment of the disease is a very important part for the specialist in PRM, because the use of drugs should be addressed to not only to just control some symptoms, but we have to control the symptoms to promote the recovery. So which is quite different. So my presentation, of course, will be very short, but just to focus on some aspect of the pharmacological treatment. This is one point is promote the recovery of consciousness and promote the plasticity, improve the cognitive performance, controlling behavioral impairment, and controlling the epilepsy. And at the end, we can give a final overview open to the discussion and question. So, of course, the phases of TBI treatment, we can mention 3 phases. One is acute phase, the second is subacute phase, which is the rehabilitation phase, very important for us, and the chronic phase. Of course, we don't have the time to focus on the acute phase. There are a lot of studies aimed to control the worsening of the brain injury in the acute phase. So we focus just about the drugs that are useful for the rehabilitation. So in the past years, 7 years ago, we did a survey in Italy in order to focus which kind of drugs we used in, for example, to promote the recovery from vegetative status and minimal conscious states. So the main use was of course anti-epileptics that are not drugs aimed to recovery, but to control the possible epilepsy crisis. the anti-Parkinsonian drugs and CNS sedation. So there is no unique approach, and was a bit confusing. So what are the tools that we have in as the pharmacological treatment to improve the recovery of consciousness? Of course, we have several drugs that has been studied. One is the CNS stimulants that the specific pharmacological profile. Of course, we focus just in few drugs, but the very important are amantadine and amphetamine. And we have also the antidepressant, especially SSRI and tricyclics, that can lead to the improvement of the arousal. So we have the bromocriptine also as the dopaminergic drug, the L-DOPA, and the methylphenidate, pramipexole, that is another dopaminergic drugs. And we have a paradoxical effect, because we are going to see that the drugs that are prevalently CNS depressants, such as baclofen, lamotrigine, zolpidem, can be used to promote the recovery of consciousness. And so we can start from the amantadine, that is a gold standard about the use of the drug to promote the recovery of consciousness, because there was a very important RCT done from the group of Giacchino in USA, but was a multi-center study that showed that the amantadine promote the recovery, the fast speed up the recovery in patients with the minimal conscious states. So this is the drug that we use as the gold standard in the post-acute phase to promote the recovery of consciousness. Of course, we ought to be careful, because we have this effect, but we have the side effect, because the threshold of the epilepsy is decreased, so we can promote some epileptic crisis, and also the effect in the cardiac effect should be facilitating effect on the arrhythmia. And now I'm going to speak about the paradoxical effect of the baclofen. This was one of my cases a few years ago. It was a traumatic brain injury. You can see that there is spastic dystonia, generalized syndrome, with MCI, so minimal conscious states, anarchic, and so the conscience was very low. And after 9 months, we applied baclofen pump, and we obtained in a few days the bracket awakening of the patient. Just started to have the contact with the environment and started the recovery. And after 1 year, so you can see here that there was the recovery of the working, of course, with the walker, and still now is it's quite bright with a small cognitive problem, and of course is in a wheelchair, but with the spasticity well controlled, but especially the recovery of the cognitive function was very important. So we didn't publish this study, this case, just to say, okay, it's evident, because we decrease the cage of the spasticity, promoting the movement. This was our interpretation. This is the pump, so you know that is a system that you can use, putting this pump with the baclofen inside, and the catheter that lead the baclofen into the CNS, in the CNS fluid, so the drug can go around the brain and act as antispastic mainly. after a few years, talking with Marco Sarà, he say, okay, it's worth to publish this data. And so this is, he published a series of cases of patients with minimal conscious states. This is the baseline. So you see the CRS, the score of CRS was very low, and after the application of baclofen, they obtained the recovery of the consciousness. So this is another example of to confirm the observation in the single case. So what is the reason for that? One of the reasons could be the modulation of spinal segmental activity and the modulation of sleep wave cycles. But going to an overview, we can say, of course, it's important, the modulation of sleep is important. Also, for me, it's very important, the decrease of the cage effect of the spasticity that block the voluntary movement. And if all the movement are blocked, including the muscles for speech, it's impossible for the patient to have the contact with the environment. So this is, I think, is one of the effects. And of course, another important effect is the decrease of pain, because if the patient with a low consciousness is attracted, the attention is attracted to the pain, of course it's very, very difficult to put the attention outside the body. So the control of the pain is very important. We don't have the time to speak about the decrease of the pain, but it's very important also to lead to the recovery of the consciousness. So the modulation of the noise that comes from the afferential sensation, and the noise could be an effect that is against the recovery of the consciousness, because the inhibitory effect could increase the filter activity, especially from the thalamic nuclei. Another drug that we use usually for the insomnia is zolpidem, but also in this case there was some description of the dramatic improvement of the consciousness in some cases. So also in this case it's very strange, and the effect is paradoxical, but could be explained as I explained the effect of baclofen. Of course, a big study with 60 patients in the chronic phase and vegetative status of minimal conscious status, and they showed that in this case there was an improvement in the 20% of the cases in an open label study. So the zolpidem is another drug that could be tried in case that we fail to obtain the recovery. But it's very important also to promote the plasticity. This is very tricky discussion because the baclofen is, and in general the GABAergic inhibitor goes against the plasticity, and so in some colleagues say, okay, I don't use it because I go against the plasticity, but go against the plasticity is not really a negative effect, because if the plasticity create some problem, it's better to decrease the plasticity in some phases of the recovery. But now it's clear that after the traumatic brain injury, there is not just the effect of the lesion, but there is a strong inflammation reaction, mainly because of the blood-brain barrier is damaged, and so there are the cytokines that go inside and increase the lesional effect. And also there is the problem of neuroprotection, that should be important in order to avoid this inflammation effect. So there are several drugs that are used, a series of drugs that, and especially the antidepressant SSRI are showed in this case was the fluoxetine in the adult rats that shows that there was an increase of extra hippocampal neurogenesis. And this leads to a series of studies in humans that show some evidence that there is not only the antidepressant effect from the serotonergic antidepressant drugs, but also a specific promoting of plasticity. This is a series of studies that are used to as the therapeutic drugs with anti-inflammatory action for TBI. So you see there are several trials, unfortunately small trials, but enough to do the meta-analysis. And so you can see here that in the meta-analysis, I moved the. In the meta-analysis that there are some drugs that is in favor of the effect. So also this type of drugs should be promising in order to be used as the drugs in case of traumatic brain injury. So another aspect is improving the cognitive performance. And also in this case, we have the drugs that are similar to the previous, because also in this case we need the stimulation of central nervous system. So in this case we have the methylphenidate, the modafinil that rise the alertness by the modulation of noradrenergic and dopaminergic system. Also in this case, the atypical antidepressant or the typical antidepressant serotoninergic can be used, especially if they have a mixed effect in the serotoninergic and noradrenergic systems. Also, the anticonvulsant could be used in order to control the neurobehavioral disorder because the stabilization effect. And we can use also the anti-acetylcholinesterase inhibitors to improve and to promote the stimulation of the CNS. So the methylphenidate is used, and some studies show that improve the working memory after the TBI. This is the Cochrane meta-analysis looking at the modafinil effect versus placebo. You see that there is no big effect on the mental function. Of course, there are the analysis is go through the different cognitive problem, but there is not much effect. And a bit of effect you can see in the visual motor speed improvement. So there are small improvement, but it not seems very important to improve the outcome. And of course, there are the dopaminergic drugs that are useful to promote the alertness, initiation, and attention. So one is the bromocriptine that acts directly in the dopaminergic receptor. And there are also the NMDA, the ADA receptor antagonist that, of course, the amantadine that could be used not only for the improvement of consciousness, but as the tool for the improve of the cognitive impairment. And the modern version of the amantadine is the memantine that is used for the dementia. So we can use also these drugs for this aim. Of course, we have the acetylcholinesterase inhibitor, and there are some studies that shows that they improve the memory, and also some alpha 2 adrenergic agonists can have some effect, but not very important. So we saw that there are the mixed effect about the behavioral problem that is linked to the cognitive function on one side, and the other side is a psychotic organic psychosis. So of course in the traumatic brain injury we don't have one or the other, but we have a grayscale. So we can have the patient that have mainly cognitive deficit and the other patient that have mainly the psychosis. This is very important to discuss, because if you have the deficit, the cognitive deficits, you have a problem interpreting the environment. So you can increase the alert, and you can increase also the aggressivity toward so in this case, of course, the CNS stimulating drugs should be useful. But on the other side, if the behavioral problem are linked to the psychosis, that means that there is a dopaminergic overactivity, there is the delirium. In this case, if you use the stimulants, so you worsen the problem. So in this case, you ought to use anti-dopaminergic drugs. But if you use the anti-dopaminergic drugs in cognitive deficit, you obtain, of course, the reverse effect, because you decrease the performance. So, of course, it's very important to focus what is prevalent, the organic psychosis or cognitive deficit. But, of course, in the side, there is the epilepsy, because the drugs that we use can lead to the epilepsy crisis. Of course, we don't have the time because to discuss, but you can see that there are the two phases for the epilepsy. One is the acute phase, where you can have the epileptic crisis, and the late epileptic crisis. But of course, just to summarize, I can show you the meta-analysis that comes from the Cochrane collaboration. So in this case, of course, we see that in the early seizure, the anti-epileptic drugs are useful. So there is this diamond that is in favor of the use. But if we move to the use for the preventing late seizure, you see that there is no significant difference to use or not use. And of course, if there is no effect, if we use for the contrast the late crisis, of course we can risk the side effect. In this case, there is if we look at the mortality, we see that it is in favor of placebo. So of course, the final message is to use the anti-epileptic drugs to contrast the early seizures, but not use to contrast the late seizures. That so we treat them just if they occur. Of course, so the final slides is the same of the first one, and so we don't have the time to comment further this list of topics, but I hope that I given to all of us a small idea about the use of drugs in after traumatic brain injury event. Thank you for your attention.
Thank you very much, Mauro, for this very complete and interesting insight into a very hot topic and a very difficult topic. Now we are turning to something which is different from the neurological disabling conditions. We are turning into a musculoskeletal condition. The osteoporosis will be the next topic, and the presentation will be from Francesca Gimigliano, which is the president-elect of the International Society of Physical Rehabilitation Medicine and she is associate professor of the PRM department in the Department of Mental and Physical Health of the University of Campania Vanvitelli in Naples. Francesca, it's a pleasure to have you with us. The floor is yours. Thank you.
Hello, thank you. Sorry, there are some privacy settings that apparently I haven't habilitated yet. Okay, sorry. I hope everything is fine. If you can try to give me, okay. I should be able to share the screen now. It's working. Okay, thank you. So let me please first thanks again, once again, Franco Cirillo and also Eliana. And I would have thanked them also for being in Syracuse once again, but unfortunately due to this coronavirus crisis, this was not possible. And I mean, it's really pity because as already Maria Gabriella said, to be live all together, it's a completely different experience, but I hope you can have the chance to enjoy it next year. And the advantage of this webinar is the fact that we can actually deliver these lectures to much more people than we usually can, because I think that the maximum that we managed to reach in Syracuse was about 80 to 90 people. And let me start my presentation. I will try to stay in my minutes. I'm going to speak about osteoporosis, which is clearly a disease of elderly people. And you as residents in PRM or neo-specialists in PRM will for sure have some patients affected by osteoporosis. We know, in fact, that people are living longer and longer, and it is expected that in 2050, more than 1 in 5 people will be 60 years or older, and the 80% of these people will be living in low middle income countries. And that's the reason why the WHO has prepared some guidelines on community level interventions to manage declines in intrinsic capacity of older people. But it's really important that countries take the responsibility to put the preferences and needs of older people at the center, not only of the healthcare system, but of the community in general. And I take the chance here to say that it's a great period for rehabilitation, because in 2017, WHO has recognized the importance to scale up rehabilitation, launching a call for action that it's named Rehabilitation 2030, as they hope that by 2030, rehabilitation will be fully integrated in all national health systems. And this is, of course, also our hope as PRM physicians. The lengthening of lifespan has, of course, increased the number of comorbidities in older people, and increased in general the number of chronic degenerative diseases. We know now that people aged over 65 years old have 4.9 concomitant disease in mean, and these numbers goes up to 5.4 in people over 80 years old. And among these pathology, there is osteoporosis. We know that 1 out of 3 women over 50 years old will experience an osteoporotic fracture, as will 1 out of 5 men. So these numbers are really high, and we really need to take care of osteoporotic patients and to treat it well. Osteoporosis has been defined by WHO as a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue, leading to enhanced bone fragility and the consequent increase in fracture risk. It has also been identified by the US National Institute of Health as a skeletal disorder characterized by compromised bone strength, as they underline the component of bone strength in predisposing to an increased risk of fracture. And this is very important because nowadays the pharmaceutical, the drugs at our disposal actually targets the bone strength. The good news is that even though in the future there will be more and more people affected by osteoporosis, we have 2 weapons available at our Arch because we can approach these patients both with drugs and with rehabilitation. And the other good news is that available available drugs are actually supported by substantial evidence of efficacy and a favorable safety profile. And the decision on which is the appropriate drug to give to our patients should be based on age and life expectancy of patient, BMD values, some non-modifiable risk factors for osteoporosis, or for factors that would increase the risk of a fragility fracture like falling, concomitant diseases, and above all, cost effectiveness and risk effectiveness of drugs. The not very good news is that up to half of people usually stop their treatment after only 1 year because not all drugs, anti-osteoporotic drugs, have the good compliance and adherence to treatment. And the other bad news is that there is still a high rate of underdiagnosis and undertreatment, above all in secondary prevention. That would be in those people who have already experienced a fragility fracture. Available drugs can be broadly divided into anti-resorptive and anabolic drugs. Anti-resorptive drugs have help the bone to prevent bone loss, while anabolic drugs actually have the power also to favor the making of new bone. And both kinds of drugs should be prescribed in association with calcium and vitamin D. All these therapies have shown to be effective in preventing vertebral fragility fractures. Most of them have been shown to be effective in preventing also non-vertebral fragility fractures, and some of them also in preventing the hip fracture, which is considered as the worst case scenario because we know what is then correlated with the event of a hip fracture. Bisphosphonates are probably the most commonly prescribed drugs for osteoporosis. They can both increase the bone matrix and bone density, but they have no power to improve the bone microarchitecture because they cannot stimulate osteoblastic activity, but they only stop osteoclastic activity. And unfortunately, they have, it is reported with the bisphosphonates, and particular with oral bisphosphonates, a low adherence and persistence to treatment. The denosumab instead can be considered as an advancement in anti-resorptive therapy, as it is supposed also to stimulate osteoblastic activity in specific areas of the cortical bone, and this has also less issues regarding adherence and persistence to treatment, as in this case the administration is one injection in the subcutaneous tissue every 6 months. We can also prescribe hormone therapy, and among the possibilities that we are available on the market, there are many kinds, multiple brands of estrogens. There are the so-called selective estrogen receptor modulators, and there are some combinations that are called tissue-specific estrogen complex that are a combination of estrogen and estrogen agonists and antagonists. As for the anabolic drugs, you probably well know the teriparatide. The teriparatide is now being commercialized for years, and it has the ability to stimulate bone formation, enhancing bone resorption, generating a period that it's called an anabolic window, in which there is the maximal anabolic effect. The problem with teriparatide is that nowadays it's prescribed as a daily injection, which is not so well tolerated by patients. But new formulation of this drug have been explored and investigated both in animal and human models, demonstrating not only to be as effective, but to be more tolerable than the subcutaneous injections, and so potentially can improve compliance to anabolic treatments. An analog of teriparatide is abaloparatide. It also addresses the PTH type 1 receptor as the teriparatide. This receptor exists in two conformations, that is the R and RG conformation, and the abaloparatide has demonstrated to be able to bind the RG conformation of this receptor at the same with the same affinity as teriparatide, but it has not the same affinity as teriparatide in binding the R conformation of this receptor. And although this drug has been approved by the Food and Drug Administration for clinical use in 2017, we are not going to use this in Europe because the European Medicines Agency refused to market this drug because they consider that the benefits of this drug will not outweigh its risks. Another option are the anabolic drugs targeting the Wnt signaling. I don't know if the arrows on my computer is working, but the Wnt is a protein that binds this receptor, fritzling this membrane receptor, and provoking the phosphorylation of the beta-catenin, and then which favors that the beta-catenin enters the nucleus, activates this receptor, and activate the osteoblastic proliferation, differentiation, and function. What happens with sclerostin? Sclerostin and DKK1 are two proteins that actually compete with the Wnt protein for binding this receptor, stopping the possibility of the beta-catenin to enter the nucleus. So the new drugs that are now being produced are antibodies directed against the sclerostin or against the DKK1, so that these two proteins wouldn't compete with the Wnt signal, and this would increase the proliferation, differentiation, and function of osteoblasts that, as you know, are the cells that produce new bone. Romosozumab is the first monoclonal antibody binding the sclerostin that have been commercialized and that have been tested actually in humans. And its mechanism of action includes the stimulation of bone formation and also the reduction of bone resorption. And the results of the available studies are actually very promising. A very new concept is the one of sequential therapies. We have actually three different possibilities, because we can prescribe an anti-resorptive drug followed by an anabolic drug, followed by an anti-resorptive drug, or we can co-administer anti-resorptive and anabolic drugs. Actually, due to costs of the drugs, the usual practice is to prescribe first an anti-resorptive drug, then followed by an anabolic drug, because usually we have to prescribe, at least in Italy, we have first to prescribe an anti-resorptive drug like bisphosphonates, and then when these drugs are not functionally fully, that means that the patient has a fracture during while he's under treatment, we can change therapy and go for an anabolic drug. Unfortunately, this is, according to some study, not the best way to switch drug, because the other option, that is prescribing first the anabolic drug followed by anti-resorptive drug, is what works best. And this is something that it's only happening now when we prescribe teriparatide to a patient who has already sustained several fragility fractures, and then it passed the maximum period for which it can take teriparatide, and so we switch this patient to denosumab. And in this case, as you can see, there is the patient switching from teriparatide to denosumab continue to report an increase in BMD, while for the other kind of switching, then from denosumab to teriparatide, actually there has been reported a bone loss. As for the co-administration of anti-resorptive and anabolic drugs, the case is different, because, for example, in the first picture, you can see that there is actually no difference in giving the parathyroid hormone or the alendronate, or a combination therapy between parathyroid hormone and alendronate. I mean that the combination, it's not better than giving one of the three drugs alone, while positive studies are instead, positive results are for the combination of teriparatide with zolendronate, or the combination of teriparatide with denosumab. Oh, sorry. I cannot finish my presentation without saying once again, and probably you heard that about this a lot, that we cannot prescribe only antipsychotic drugs without taking into account that patients have to take a minimum daily intake for both calcium and vitamin D. There are many foods that contain calcium, so we need to make sure that our patients regularly consume these foods, while unfortunately vitamin D is not contained in so many food. And we know that vitamin D is actually essential for the development and maintenance of bone, for the assumption and the absorption of calcium, and for ensuring the mineralization of bone tissue. So usually supplementation for vitamin D is necessary and mandatory. And my take-home message for you is this, that as for the aging of the population, you will have osteoporotic patients to treat. The only thing we have to make sure is that osteoporosis is diagnosed in time before the patient sustain a fragility fracture, and to make sure that all patients who sustain a fragility fracture are treated for osteoporosis. The positive thing, as I said, is that commercially available anti-osteoporotic drugs are effective and safe. But the important thing is to explain to our patient that they have to stay on drugs, because otherwise the effects cannot be delivered. And before thanking once again all of you for your attention and Franco for inviting me to present this lecture, I like, as President-elect of the International Society of Physical Rehabilitation Medicine, to welcome you to the International Rehabilitation Week. In the week from November the 30th to December the 4th, we will have a series of events and lectures dedicated to rehabilitation in order for the general public, in order to raise awareness on rehabilitation. So you are invited to follow these events on E.M.R.S.S social media. Grazie ancora per l'attenzione a tutti.
Thank you very much, Francesca. We will turn again into something that deals with neurological disabling disorders. The next speech will deal on spasticity, and the speaker is Michele Vecchio, Associate Professor of Physical Rehabilitation Medicine and Director of the Graduate School of Physical Rehabilitation Medicine at the University of Catania, Italy. Michele, it's a pleasure to welcome you, and the floor is yours. Okay, I ask Francesca to leave the screen, or okay.
Un attimo, non riesco a...
Okay. Okay, Michele, we can hear you.
Ok, condividi. I will sound difficult to take my slide.
You share the screen?
Sorry, I don't know why. I'm not able to take. I can try to.
Okay. Now is okay. Okay.
Okay. Sorry.
Okay, here we are. Thank you.
So good afternoon to everybody. I'm Professor Michele Vecchio, and thanks Professor Cirillo and our chairman. I'm very happy that also this year we are present at this event of Euro-Mediterranean School. We know that a brain injury can result in functional, motor, and cognitive deficit. Today, I will present a method of clinical assessment of motor deficit in order to assess which muscles are paretic, which are hypertonic, and which are contracted. We will use botulinum toxin drugs for hypertonic muscle, but we have first to perform a correct evaluation. We know the three main factors of motor impairment following a lesion. In chronological order, stretch-sensitive paresis, a reduction of agonist motor unit recruitment upon voluntary command. 2, soft tissue contracture. When the muscles are immobilized in shortened position, gene change as soon as a few hours, hindering to protein synthesis modification. Muscle plasticity start soft tissue contracture, which involve muscle, tendons, ligament, joint capsule, skin, vessel, nerve, and follow, we have loss of sensibility, we have loss of mass, slow to fast change in contracted muscle properties. 3, muscle overactivity. Muscle overactivity includes spasticity, an increase in the velocity-dependent response to muscle stretch. Spastic dystonia is a chronic tonic muscle activity at rest. And spastic co-contraction, an antagonist contraction during voluntary agonist command. We need to be able to clinically distinguish these three aspects. I invite you to read this interesting and clear paper by Jean-Michel Gracier, a 5-step of clinical assessment. A 5-step clinical assessment in which the first 3 steps aim to quantify the antagonist potential of each muscle group. So step 1 measures the range of motion of passive movement. The angle of arrest following a slow stretch provides information on the presence of contracture. Step 1. Step 2 measures the angle of catch or close upon fast passive stretch of the muscle group assessed. If the catch occurs before the range of motion performed with the previous slow test, we can suspect a hypertonia of assessed muscle. Step 3 measures the range of active motor, so the active motor of the subject is a net result of agonist recruitment minus the resistance from passive soft tissue stiffness and spastic co-contraction in the muscle group assessed. So we have these 3 steps to study and to assess the spasticity and to understand if the muscle is contracted or spastic. Now I want to show you a video that teaches the clinical evaluation to subjects suffering from spastic paralysis in order to quantify his motor impairment and to evaluate if and how much his segment shows paralysis and or spasticity of contracture. The first part of the video shows a clinical assessment. After shows the treatment with botulinum toxin in order to reduce spasticity in the muscle affected of spasticity. And finally, it shows the assessment of the obtained result.
We are presenting the evaluation of a spastic patient The evaluation of a patient who had hemiplegic stroke starts from analyzing his deambulation. Right now, we are applying the scale of Tardieu. This scale permits us to assess whether the patient is a spastic patient or has become a condition of muscle contraction. In this case, V1 and V3 has the exact same angle, so the patient has no spasticity on his shoulder. In this image, we are asking the patient to actively flex his shoulder so that we can understand that he shows a deficit in the recruitment of his levator muscles of the shoulder, while, as already said, there is no spasticity or retraction of the antagonist muscles. Tardieu scale on elbow shows the difference of angle, which V1 is 175 degree and V3 is about 90 degree. Therefore, there is spasticity on flexor elbow muscles. This method of evaluation can be used on any joint, the wrist, the fingers, the knee, the ankle. In this case, you can observe that our patient has spastic quadriceps because V3 is about 45 degrees and V1 is about 90 degrees.
This is a step 1, range of motion, passive movement. The angle of arrest following a slow stretch provides information of the presence of...
Then we apply a less intense force with a very rapid movement, and we observe if there is catch ahead of the movement executed slowly. In this way, we observe if the soleus muscle and the gastrocnemius muscles are hypertonic. Remember that spasticity is speed dependent. Finally, we ask to perform an active flexion of the ankle, and we observe that the patient is not able to do this. Now we repeat the same test, but with the bent knee. In this way, we mainly examine the soleus muscle. Then we apply a less intense force, but at maximum speed to highlight a possible catch that interrupts the movement earlier than the angle of movement obtained with the slow movement. It is necessary to write all the angles obtained with each maneuver in order to evaluate if our patient has muscular contractions or spasticity of the antagonistic muscles or weakness of the agonists, or has a condition characterized by the various components together, and in order to evaluate the success of our rehabilitation treatments. Injections of botulinum toxin with ultrasound guide or with needle electrostimulation, as we see in this case. Electrical muscle stimulation is very helpful in making sure that the drug is injected into the muscle we want to inject. With needle electrostimulation, we see the contraction of the muscle we are treating. Now we are going to treat the quadriceps muscle. Here you can observe after a week from the treatment with botulinum toxin, the excellent result on a patient measured by Tardieu scale. Finally, we ask for an active flexion of the ankle. Remember that the patient was unable to do this before. Now he begins to recruit the agonist muscles and manages to perform a dorsiflexion of some joint degrees. The quadriceps exam is very significant. The slow motion test is roughly the same as the test performed before botulinum toxin treatment, as there was no muscle contraction. The elbow flexor test appears significant where the slow maneuver is almost equal to the same maneuver performed before the treatment, since there was no muscle contraction, while fast does not show the catch that we had found before the treatment, since the spasticity is significantly reduced. Here you can observe the improvement of the capacity in velocity, stability, and force of his steps. Overall, Tardieu scale is significantly more precise than the Ashford scale, which is commonly used in the most clinical studies and scientific papers.
Okay, so before to use botulinum toxin to reduce spasticity, we have to be sure that muscles are hypertonic. This is the view of success of our treatment. We are sure that muscles are hypertonic when we perform the Tardieu scale. Is a clinical simple scale without any instrument, and that we can have some precious information about contracture when the range of motion is slow. When we do the range of motion slow and we don't have any catch, we can measure the angle of catch of conus upon fast movement stretch of the master group assessed. If the catch occurs before the range of motion performed with the previous slow test, we can suspect hypertonia. And then we can measure the range of active motor. It is a net result of agonist recruitment minus the resistance of passive soft tissue stiffness and spastic contraction of the group, muscle group assessed. Okay, thank you very much.
Thank you very much, Michele. Thank you very much for this very practical information and updated information. And now we will turn into another important issue, that of neurological bladder. The speaker is Stefano Carda, Deputy Head Service of Neuropsychology and Neurorehabilitation in Lausanne, Switzerland. Stefano, welcome with us, and the floor is yours.
Thank you. Thank you, Paolo. Thank you also to Franco Cirillo for the kind invitation. Just let me go to the presentation. Can you see that now? Is it okay?
Okay, go on.
Okay. I can go on, thank you. So, managing the pharmacological treatment of neurogenic bladder. First of all, I can start with just a reminder about the bladder innervation. Bladder innervation, as you know, has three kinds of different innervation. One is the parasympathetic, the other the sympathetic, and the somatic system. The parasympathetic starts from the nucleus in S2, S4 metamer, and the preganglionic fibers travels through the pelvic ganglions, and the postganglionic fibers, which are very short, intramural, are mainly in the detrusor and bladder neck. The action of the parasympathetic is mainly the detrusor contraction via the muscarinic receptor M3, a small contribution of M2, and also a small contribution of purinergic signaling. And the other is the opening of the bladder neck and the internal urinary sphincter through the nitric oxide. The sympathetic system origins in T10 L2 metamers, and the preganglionic fibers get to the mesenterical ganglion, and the postganglionic fibers, which are long, travels to the hypogastric nerve, to the pelvic ganglions and the pelvic nerves. The action of sympathetic system on the bladder is the bladder neck and internal urinary sphincter contraction via the alpha-1 receptor, and also the detrusor relaxation via the beta-3 receptor, both noradrenergic. We have, the somatic system. The somatic system travels through the pudendal nerve, which is a mixed nerve, and the nucleus is again in S2, S4 metamer. This controls the external urinary sphincter and the pelvic floor contraction via the nicotinic receptors. We have two reflexes that controls our bladder. The first one is the guarding reflex. What happens? Bladder distension, when urine gets into the bladder, provokes a low-frequency discharge, which is transmitted by the pelvic nerves to S2, S4. And this stimulates the sympathetic T10L2 with detrusor relaxation and the closing of the bladder neck and the internal sphincter, and the pudendal nerve nucleus with the closing of the external urinary sphincter. This reflex is controlled by a tonic activity of the from the Pontin storage center. Then the micturition reflex. When the volume of the bladder gets to some level, usually is over 200 milliliters, the firing frequency to the pelvic nerve increases, and this activates the periaqueductal gray, which activates the Pontin micturition center, called also the Barrington's nucleus. And this inhibits the thoracolumbar sympathetic system first, and inhibits the pudendal nerve nucleus, and activates the sacral parasympathetic. In turn, we have the contraction of the detrusor, the opening of the neck and the internal and external sphincter, and the micturition. Now, If we talk about the neurogenic bladder, the neurogenic bladder can be provoked by lesions of central or peripheral nervous system, and the pattern can be very complex and also varying during time. The most used classification is the one published by Maders-Bacher in 2002, which divides the neurogenic bladder in 4 types. The first type is the supraconal spinal cord injury, in which both the detrusor and the sphincter, internal sphincter, are overactive. Type 2 or conal spinal cord injury, in which the sphincter is overactive, but the detrusor is hypoactive. The third is the caudal lesion, in which both are hypoactive. And the fourth is the suprapontine lesion, typical of stroke, for example, in which the detrusor is overactive and the internal sphincter hypoactive. We have some clinical features that may help us differentiate the neurogenic overactive bladder from the stress incontinence, which is very frequent, mainly in women. First, in neurogenic bladder, the patient has urgency, a strong sudden desire to void. There's a high frequency, pollakiuria. There is usually no leaking during physical activity, which is present in stress incontinence. And the amount of leakage is very large, and usually patients have to wake up to pass urine at night, and they don't have the ability to reach the toilet in time after a urge, which is the case in stress incontinence. So first evaluation is clinical. Then the treatment of neurological bladder. We have to be aware that at present time we don't have drugs to treat sensory problems and hypoactivity of the detrusor or pelvic floor or urinary sphincter, both internal and external. This is the role of rehabilitative modalities, which are very important. But we have different treatment, have behavioral, time-dependent voiding, reflexive voiding, the intermittent clean self-catheterization, permanent catheterization, surgery, palliation as diapers, and drugs, which are the focus of this presentation. As a rehabilitation specialist, we have to be careful about the goals of neurogenical bladder treatment. What do we want? The goal of the patient is to be dry. So the first goal is continence. Then there are goals of the rehabilitative team, the doctor, nurses, and so on, and is to preserve the higher urinary tract from renal failure and to prevent or minimize urinary tract infection. So when we treat a patient with neurogenical bladder, we have to keep in mind these 3 main goals and try to achieve them. The pharmacological treatment is mainly based on 4 pillars. I have added also desmopressin at the end, but the first drugs are the most utilized. The anticholinergic drug, beta agonist, alpha agonist, botulinum toxin type A, and desmopressin. Anticholinergic drugs, they all act on M3 muscarinic receptor as antagonists. We have oxybutynin, oral or transdermical, tolterodine, trospium chloride, solifenacin, darifenacin, fesoterodine. Now, I try to show you some differences between these drugs. Anticholinergic drugs have a good efficacy. Nearly 60% of the patients report improvement in their symptoms. But after 1 year, nearly 40% stop these drugs due to side effects. Side effects are cognitive on the brain, somnolence, cognitive decline, constipation, blurred vision, dry mouth, and flush. For oxybutynin is metabolized by the cytochrome 3A4, and the active product produces the side effects. So the transdermic oxybutynin avoids the first pass effect and reduces side effects. But the problem is that we don't have enough data to recommend it in neurogenical bladder, but only in overactive bladder, non-neurogenical overactive bladder. Tolterodine is metabolized by the 2D6. We have less blood-brain barrier crossing than oxybutynin and less cognitive side effects. Trospium is not metabolized by the cytochrome. It is excreted unchanged in the urine. It has a slower effect, a low bioavailability, but lesser side effect and less interaction. So it can be a good option in elderly patient or patient with multitherapy. The darifenacin is metabolized by both cytochrome. It has a great N3 selectivity, so we have few side effects, but the risk of interaction is higher. If we talk about the cognitive side effects, we know that the trospium has fewer side effects than oxybutynin and tolterodine. The darifenacin hasn't shown any cognitive side effects in the clinical trials, but oxybutynin, which is the most utilized in the world, has constantly shown cognitive side effects. We have contraindication as closed-angle glaucoma, myasthenia gravis, megacolon, ileus, COPD, asthma. And that's why the pharma has tried to develop a new drug, which is a new family, the beta-3 agonist. The first, the only one at this time available on the market is mirabegron, 25 to 50 milligrams per day. It is a beta-3 agonist selective with a good evidence of efficacy in overactive bladder, but lesser evidence in neurogenic overactive bladder. And we have to be careful because most studies utilize only urodynamic outcomes and not clinical outcomes to evaluate the effectiveness of this drug. So it has to be considered as a second-line treatment after anticholinergic drugs. The side effects are tachycardia and hypertension. And you should be careful that it is metabolized by the cytochrome 3A4. So you must not associate it with powerful inhibitors, fluconazole, clarithromycin, erythromycin, grapefruit too. And it is also metabolized by PGP. So we have to monitor therapy when you add mirabegron to other drugs metabolized by PGP, as for example, dabigatran. The alpha-1 blocker, it's a class of drugs, quite old. The most utilized are alfluzosine, tamsulosin, terrazosine, doxazosine, and silozidine, with the different dosage that you can read. These drugs can open the bladder neck. So they are active on obstructive symptoms, which are present also in neurogenic bladder. They produce frequently orthostatic hypotension, and doxazosine and terrazosine are clinically the less tolerated, and alfluzosine the better tolerated. The other side effects in male are ejaculatory problems up to an ejaculation, and we know that alfluzosine seems to be better tolerated. Again, these drugs are metabolized by the cytochrome 3A4, so we should avoid the concomitant administration of clarithromycin, voriconazole, and antiretroviral drugs, and to be careful with the moderate inhibitors as fluconazole, dithiazem, verapamil, and grapefruit to avoid too much side effects. Remember also that these drugs are partially metabolized by the 2D6 too. Then botulinum toxin type A, I must thank Professor Brigitte Schursch, which invented this kind of treatment that has revolutionized the treatment of neurogenic bladder 25 years ago. Botulinum toxin type A blocks acetylcholine exocytosis at the neuromuscular junction, and this drug needs to be injected in the detrusor. So the problem is the administration of the drug. We have a strong evidence that is effective in clinical and urodynamic outcomes. The proportion of patients which are dry after this treatment is near the double of those dry with anticholinergic drugs. But we can use it only in patients that hasn't been controlled enough with oral drugs. The dose is for onabotulinum toxin type A from 100 to 300 units with a level of evidence 1A, and for A-botulinum toxin A, 75 units with a lesser level of evidence. The duration of effect is very long, usually is 9 months, between 8 to 12 months. But we have, again, some side effects. Some are procedure-related, so the urinary tract infection, the bleeding, and other are drug-related. The real side effect drug-related is transitory myasthenia, which is rare. The other is the effect of the drug, the urinary retention. And nearly all patients that has been treated with the full dose of 200, 300 units of onabotulinum toxin need intermittent catheterization after the procedure. So in patients with incontinence and neurogenical bladder, we perform toxin only after an education on self-catheterism. Even in the patient, for example, with Parkinson's disease and multiple sclerosis, in which we usually start with a dose of 100 units, again, onabotulinum toxin. I end with desmopressin. Desmopressin is not really a drug for neurogenical bladder. It's an hormone, and it can be used to reduce the nocturnal polyuria. So it's the drug that we use for diabetic insipidus. And we can use it to avoid the nocturnal catheterism. We know that, for example, a patient with spinal cord injury can have an alteration in the secretion of the antidiuretic hormone, and to have polyuria during night. We can use it to reduce the need of a catheterism during the night, or for patients with stroke or Parkinson's disease or multiple sclerosis to avoid to wake up at night and reduce the risk of falls. It can be administered intranasally, 10 to 20 micrograms. The side effects are hyponatremia, headache, and hypo or hypertension. In my experience, mainly hypertension, and mainly in patients with Parkinson's disease and autonomic dysfunction. I just end with the ICS, International Continence Society Guidelines 2019, is the management of neurogenic urinary incontinence. As you see, after the history and clinical assessment, we have to check the post-voidal residual volume after the bladder emptying, and if the volume is higher than normal, so a patient has retention, there is intermittent catheterization with or without antimuscarinics. If the residual volume is negligible, we have behavioral modification, level A antimuscarinics, level D beta-3 agonists, continence products, or an indwelling catheter. If this treatment has failed, we have to go to specialized treatment with a neurodynamical testing, and then you see that the picture is a little bit more complex. Now I've ended my presentation. Thank you for the attention.
Thank you very much, Stefano. You are in perfect time. Okay. Thank you very much, really. And, okay. Thank you.
I think it's okay. I stopped the.
Okay. You just should shut the macro. Thank you, Stefano. Okay, perfect. The next speaker is Roberto Casale. He's the scientific director of Opus Medica, a person's care and research in Piacenza, Italy, and he's a very well-known colleague in working since a long time in the area of pain. It's his favorite topic, and his presentation will deal on how to manage the pharmacology of pain, which is a huge topic. So thank you for coming, Roberto, and the floor is yours.
Can you hear and see me?
Yes. Okay, perfect.
So thank you very much, Paolo, for the kind presentation. Thank you also to Franco Cirillo, which is the heart of the Mediterranean School. My topic is about the rational use of pharmacological treatments for chronic pain in rehabilitation. As you can see in the first slide, I want to stress the rational use, not the use, and chronic pain, not acute pain. So, what is important is just to define what are the key types of pain where we have to deal in clinical practice. And of course, the major divisions are between nociceptive pain, which is a pain caused by an inflammation or a non-inflammation response to a noxious stimulus. In other terms, we have to deal with a tissue damage and a chemical activation, in which osteoarthritis is one of the most important pathology related to nociceptive pain. But on the other side, we have the neuropathic pain, which is a pain initiated or caused by a primary lesion or a disease in the peripheral or central somatosensory system. And of course, we are talking about nerve and central nervous system damage. And in this part of the pain family, we have to deal mainly with ion channel changes. Of course, in the clinical practice, both types of pain can coexist. And this makes the therapy a little bit confused, because sometimes we are using a drug which is mainly for nociceptive pain, and we can obtain fantastic results, even if in the same patient we have also a neuropathic component. So to deal with the rational use of drugs in the treatment of chronic pain, we have to deal with both of these type of pains, and to know what to have a chronic pain means. So the definition, I don't want to bother you about the definition, because you already know. But what I want to stress is that chronic pain is a disease. It's not a symptom. And chronic pain is not simply acute pain that lasts longer. It's a disease in its own right, with different mechanisms from acute pain. So to talk about chronic pain doesn't mean to have to consider what we are using in acute pain control. And just because we are in a rehabilitation context, we have to stress the fact that chronic pain is a disabling disease. So chronic pain is a matter for rehabilitation. So we have a lot of inputs from the periphery, conveying touch, temperature. Also, we have nerves conveying painful messages, heat messages, mechanical and chemical messages that are coming from a tissue or a nerve damage. All these incoming inputs from the peripheral nerves go to the spinal cord, the dorsal horn of the spinal cord. And the spinal cord integrates, amplifies, and modifies the incoming messages with a sort of bottom-up processes from the periphery to the brain. But the spinal cord, as I said, is sending informations to the upper centers, mainly to, I can't see, okay, it must be something related to the cortex in the upper right corner. Okay, for the localization and for the quantification of the intensity of the stimulus. But in parallel, the stimulation goes also to other come on, to other areas in the brain, and mainly in the limbic brain for the affective aspects of pain, including fear, anxiety, sleep, and mood disorders related to chronic pain. But when the pain reaches the central nervous system, not only it gives sign of its presence. So the brain is not only receiving the information, oh, I have something very bad in my feet, but also it activates descending controls, allowing a sort of top-down processes to enhance and control pain. Enhance and or control. It means that the nervous system in the upper part, I mean the brain, has the ability not only to reduce pain, but also to emphasize the perception of pain. And this depends mainly on the central reward and the presence of comorbidities. So we have inflammation, and we are talking about peripheral sensitization. We are talking about the increased response of nociceptors in periphery. It means that the receptors are decreasing the threshold of activation, therefore they are enhancing their response. But if we have a nerve lesion, so we are a little bit closer to the central nervous system, we have very high numbers of electrical events like ectopic discharge, cross-talking, and we have mainly an involvement of the so-called NaV17 and 18 ions channels, and they are channels related to sodium. And this is important because if we want to go to look at some treatments for the periphery, we have to distinguish between peripheral pain coming from an inflammation or coming from a nerve lesion. In the first case, we can use some drugs. In the other case, we can use, for instance, sodium channel blockers. So we have a peripheral activity coming from the skin, inflammation, and from a nerve lesion. Both of them causes hyperexcitability and sensitization of the spinal cord. So in other terms, we are going from the periphery, in which we have more tissue lesion, we have more nociception, toward the central nervous system, in which we have less nociception, less inflammation, and we have, let me say, more brain pain. Pain, it is no more related to the periphery. The pain goes to the central nervous system, creating a huge number of modifications in terms of sensitization that we call sensitization. And then, as we said, we have some descending pathways coming from the activation of the central nervous system. And we have two different types of descending fibers, noradrenergic and serotoninergic descending pathways. The first one has a sort of protective effect, while the second one promotes the perception of pain. So here we have a nice sample on how to use antidepressants, for instance. But don't forget that possibly these two systems, noradrenergic and serotoninergic systems, are in a very delicate balance. So sometimes we have an increase in noradrenaline, and we have to decrease noradrenaline to facilitate serotonin. On the other side, sometimes we have a very low level of serotonin, and then we have rebalance serotonin with noradrenaline. That's why we have a lot of difficulties sometimes in using antidepressants. Sorry. So, at the end of the story, as I said, the pain, the chronic pain is no more in periphery, is in the central nervous system. Is in the central nervous system where we have the so-called central sensitization. But please look at how many pathologies that we consider mainly of orthopedic, inflammatory, peripheral origin. I don't want to say fibromyalgia because we know that fibromyalgia is mainly nociceptive pain, but osteoarthritis. In chronic osteoarthritis, we have a very high level of central sensitization. In juvenile arthritis, in temporal mandibular joint disorder, which is a joint disorder, musculoskeletal pains, when they are chronic, they have all very pronounced central component. So, in other terms, the current therapeutic targets can be focused on periphery. For instance, let me see if I can. Sorry. Okay, where we can use drugs to control the nerve excitability, for instance, topical lidocaine, or drugs that can block sodium channels. Forget about antiepileptic drugs. We are not using antiepileptic drugs because they are anti-epileptic drugs. We are using carbamazepine, oxcarbamazepine, phenytoin, lamotrigine, just because they are sodium channel blockers. Of course, if we are convinced from the clinical picture that we have not only peripheral nerve lesion, but we have also some inflammation going on in the tissue, we may use COX-2 or NSAIDs drugs to control the input of informations from the periphery. Then, if we believe that the pain is no more in the periphery but is in the central nervous system, then we can use some drugs able to control the spinal cord excitability, mainly the alpha-2 delta ligands, and therefore using the so-called gabapentinoids. But we don't have to forget that we have some inborn control for pain, and we can activate or we can enhance their activity using antidepressants, opioids, and for instance, a quite new drug, which is tapentadol, which has a normal activity, is a noradrenaline opiates activity. So, if we are dealing with a very severe chronic pain, then we have to consider to have just to be in a car and having 3 possibilities to control the speed. We have the gabapentinoids that can block the calcium channel and therefore release transmitters. We have brakes that are the opioids, in which we can control and close the potassium channels. Or we have some drugs that we can use to release the speed control. And another way to control the speed, blocking the speed blocking the sodium channel activity. Here we have a sort of a compendium on what we can do. From the bottom left side, we can use lidocaine and capsaicin as well in periphery. We can use anti-inflammatory drugs. We can use carbamazepine and lidocaine if we have a neuropathic pain to block the activity of the abnormal focus along the nerve. We can use, if you want to block the spinal cord, again, the gabapentinoids, the opioids as well. And don't forget that non-steroidal anti-inflammatory drugs, they have an action also in the central nervous system. So sometimes we are using NSAIDs for as a mistake, and we may have also good results because we are thinking to control the inflammatory pain. As a matter of fact, we are also reducing pain by means of central activation. So if I may have a few minutes more, may I have? Paolo?
Yes, yes, please. Okay.
Yeah.
Some minutes. Okay.
How many?
A couple of minutes. Okay.
Couple of minutes. Okay. So if we want to activate some descending control, don't forget that serotonin and noradrenaline are in balance. So sometimes we don't need to increase noradrenaline or increase serotonin, while better we have to decrease one or to decrease the other. So this is a little bit more easy slide to summarize what we can do with drugs. And I want to leave this just to go straight to this point, just because the targets, as we saw, are many in chronic pain. We don't have only one target. We have several possible concomitant mechanisms leading to chronic pain. So sometimes one drug is not enough. So my suggestion is to think about polypharmacology with multi-target therapy, taking into account that sometimes a combination therapy have a synergic effect, just like with tapentadol, in which two mechanisms, nor more, are producing a synergetic effects. So just to remember that pain changes our brain functions, including lack of energy and fatigue, and this is a matter of rehabilitation. Again, pain as a disease, chronic pain as a disabling disease. So please don't forget that there's no rehabilitation gain without pain management. And therefore, there's no pain management without rehabilitation. This is to stress the fact that we have to use drugs to make the rehabilitation possible, and not only to control pain. Rehabilitation and the use of drugs must be together to have a better rehabilitation outcome. Thank you very much for your attention, and I hope my presentation will be of some help for your clinical practice. Thank you very much.
Thank you very much, Roberto, for your very exhaustive presentation, even in a short time. I understand that this topic would require much more time to be completely described, but I think you have been very, very helpful for not only for residents, but also for everyone who is dealing with such problems. I would remind that the participant can send messages, questions to the speakers, and we will try to ask the speakers to reply in the next days. Now it's a pleasure for me to introduce Gülseren Akyüz from the Marmara University School of Medicine of Department of Physical and Rehabilitation Medicine in Istanbul, Turkey. And the topic is a very hot and interesting topic, is the topic of degenerative and inflammatory joint diseases. So welcome, Gülseren, for being with us, and you can start your presentation. Thank you very much again.
Okay. Thank you, Paolo. Can you hear me?
Of course. Okay.
And can you see my presentation?
Yes, perfect. Okay.
Okay, thank you. And first of all, I would like to thank to Franco Cirillo for inviting me as a speaker. I believe that he is always doing a great job with Euro-Mediterranean PRM School. My topic is on degenerative and inflammatory joint diseases, managing their pharmacologic treatments. As we know that, we also know that arthritis may occur due to immunologic dysfunction and degeneration and metabolic disorders and infection. Arthritis and soft tissue problems may cause pain, physical disability, and psychosocial problems to the loss of job and socioeconomic burdens. Today, I would like I will talk about the pharmacotherapy principles of osteoarthritis, rheumatoid arthritis, and ankylosing spondylitis. As you know, there are many rheumatic diseases, but these three rheumatic diseases are very important for rehabilitation medicine physicians. Osteoarthritis, the most common joint disorder failure worldwide, can lead to disability and reduced quality of life. It is characterized by cartilage degradation, subchondral bone erosions, meniscal degeneration, synovitis, and accompanying periarticular responses. It often affects knees, hips, hands, spine, and feet. It is known to be caused by multiple factors, including genetic predisposition, joint integrity, mechanical forces, and also cellular biological processes. The main aim of osteoarthritis management is to control pain, minimize functional impairment and disability, and improve quality of life. We know that there are three components for it: non-pharmacological, pharmacological treatments, and also surgery. Non-pharmacological treatments comprises patient education, especially self-management, exercises, regular exercises, weight loss program, bracing, and also use of assistive devices. Surgical procedures include total joint replacement, arthroscopic surgery, osteotomy, and lavage and debridement of synovium. But we know that only total joint replacement has been proven effective for osteoarthritis. Nowadays, unicompartmental knee replacement has been shown to be effective for end-stage unicompartment knee osteoarthritis. Acetaminophen was previously recognized as a safe medication, but regular use of this medication may cause some side effects such as gastrointestinal blood loss, and we know that its efficacy is not as high as that of other medications. In patients with one or a few joints affected due to osteoarthritis, pharmacotherapy are suitable with topical NSAIDs due to similar efficacy compared with oral NSAIDs. When the patients have an inadequate symptom relief from topical agents, at that time we can prescribe oral NSAIDs. But we use the lowest dose required to control the patient's symptoms on as needed basis. The use of NSAIDs in most patients is limited by the increased risk of severe gastrointestinal, cardiovascular, and renal side effects. So, in patients with comorbidities such as diabetes, hypertension, and elderly people, we prefer to prescribe as cyclooxygenase 2 selective NSAID or non-selective NSAID associated with a proton pump inhibitors are the best. Topical capsaicin is a treatment option. When one or a few joints are involved and other interventions are ineffective or contraindicated, but its use may be limited by common local side effects such as skin irritation. The pain-reducing effect of opioids is modest, and considering their many side effects, so the use of opioids in osteoarthritis management is limited. We also avoid prescribing opioids due to their overall small effects on pain for long-term use in the older adult population, because the nature of pain depends on nociceptive and neuropathic factors together. For osteoarthritis patients with pain sensitization or chronic widespread pain, duloxetine, which is a selective serotonin norepinephrine reuptake inhibitor, may be effective. We do that, honestly, we do that, especially in osteoarthritis patients has fibromyalgia or something like that. Okay, yeah. And although oral use was postulated to incorporate glycosamine and chondroitin into the articular cartilage, and animal studies have supported that they may have anti-inflammatory effects. In the past few years, many non-industry funded studies have demonstrated negative results. So glycosamine and chondroitin are no longer recommended for osteoarthritis treatment today. Intra-articular corticosteroid injection can reduce inflammation and angiogenesis within the synovium. In randomized clinical trials, intra-articular corticosteroids have been proven effective in the treatment of knee and hip osteoarthritis, but their effectiveness is not long-lasting, and they may have harmful effects on the hyaline cartilage and may accelerate osteoarthritis progression. The use of systemic corticosteroids for the management of osteoarthritis is unproven, especially when we want to inject corticosteroids intra-articularly. At that time, we should be very careful to choose for the place of the joint. Hyaluronic acid intra-articular injection is believed to increase the viscosity and elasticity of the osteoarthritis joint, and previous studies have shown that it exerts anti-inflammatory and anti-nociceptive effects. It has been approved by the regulatory agency for use in the treatment of knee osteoarthritis, but however, meta-analyses have shown that this injection provides either no or only minimal efficacy. It may also increase the risk of adverse effects such as crystal arthropathy, pseudoceptic joints, and flaring of pain. So, osteoarthritis-related guidelines have either not recommended hyaluronic acid injections for osteoarthritis management or reported uncertain efficacy. Prolotherapy, also called proliferation therapy, is an injection-based therapy for chronic musculoskeletal pain. And Professor Levent Özçakar, the next speaker, will talk about the details of these injections, I know. So I want to say a few words just in case. And prolotherapy, including PRP injection, has shown short and long-term improvement on pain, function, and even radiologic features, but its application in osteoarthritis has still not been recommended by most osteoarthritis-related guidelines. Finally, it is not routinely recommended nutritional supplements such as diacerin, avocado, soybean, fish oil, and curcumin due to the lack of clear evidence in the management of osteoarthritis as a pharmacotherapy. The second topic is rheumatoid arthritis. As we all know that rheumatoid arthritis is a chronic systemic inflammatory disease of unknown etiology that primarily involves the small joints, especially, but of course, the big joints can be involved. Inflammation and destruction of the joint and soft tissue may lead to joint deformity and loss of function. The most common joints involved in the early stage of the disease are MCP, PIP, interphalangeal joint of the thumb, wrists, MTP, joints of the toes. It also often involves soft tissues, and also it can be together with extra-articular manifestations, especially vasculitis and rheumatoid lung disease or subcutaneous nodules are associated with poor prognosis. The comprehensive management of rheumatoid arthritis requires a combination of non-pharmacologic treatment, medical treatment, and surgery. Non-pharmacologic with appropriate exercises, usage of physical agents, occupational therapy, proper orthosis, shoes, and durable medical equipment. Nutritional counseling, psychosocial support, vocational training, and measures to prevent complications of drug therapy are also integral part of treatment. But rehabilitation is the best choice for the treatment of rheumatoid arthritis in addition to pharmacotherapy. In patients with unbearable pain, severe joint destruction, or poor response to long periods of medical treatment and rehabilitation, surgery is indicated. Common surgeries for patients with RA are artificial joint replacement, synovectomy, tendon repair, osteotomy, and arthrodesis. What about pharmacotherapy of rheumatoid arthritis? Today, we know that there are many alternatives for that. Sustained remission or low disease activity is the pharmacologic treatment target in patients with rheumatoid arthritis. The main goal is to achieve more than 50% improvement by 3 months and is typically attained by the 6th month. 3 classes of drugs are commonly used in the treatment of patients with RA. NSAIDs, disease-modifying antirheumatic drugs, or E.M.R.S.S. NSAIDs can reduce acute inflammation, thereby reducing pain and improving physical function. But NSAIDs alone cannot prevent the progression of joint damage and the resultant irreversible disability. In this table, you see the main disease-modifying antirheumatic drugs, E.M.R.S.S. In the left side, there are 2 types, synthetic and biological. But synthetic types are also divided into 2 groups, conventional synthetic E.M.R.S.S. and targeted synthetic E.M.R.S.S. According to the target area, conventional synthetic E.M.R.S.S. are methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine. Targeted synthetic E.M.R.S.S. tofacitinib and baricitinib. Biological E.M.R.S.S. TNF, adalimumab, etanercept, infliximab. For B cells, rituximab, T cells, abatacept, interleukin-6, tocilizumab, interleukin-1 inhibitors, anakinra. patients with RA should be treated early with DMARDs because they can modify the disease course and hence inhibit the progression of joint damage. The DMARDs currently available for RA treatment are categorized into synthetic and biologic agent, as I told you before, but among the conventional synthetic DMARDs, methotrexate should be preferred drug for RA. If it is ineffective, there is an ineffective term, at that time we can prescribe leflunomide or sulfasalazine. Conventional synthetic DMARDs may be combined with NSAIDs and glucocorticoids. Glucocorticoids are also potent anti-inflammatory drugs. They are particularly useful at the onset of the disease. Glucocorticoids are used as a bridging strategy. They are then tapered while the DMARDs take effect. When patients exhibit little response to methotrexate and even to 2 or more conventional DMARDs, it is time to start a biologic DMARD or a targeted synthetic DMARD in addition to methotrexate. Biologic therapy must be used in combination with methotrexate because the response to this combination is the best, according to biologic therapy alone. When the treatment target is not acute with the use of first-line biological DMARD, switching to another agent with a different mode of action is recommended. When a patient is in persistent remission, tapering of a biological DMARD may be considered. However, complete discontinuation of the biological DMARD or targeted synthetic DMARD is not necessary because it can lead to disease recurrence. But we know that the drawbacks of biologic DMARDs are their high cost, possible side effects, and sometimes serious adverse events. Finally, I want to say something about the pharmacotherapy of ankylosing spondylitis. The most common presentation of ankylosing spondylitis is chronic inflammatory pain that usually starts at the buttock or lower back level with possible radiation to the posterior thigh. It's a dull pain, insidious in onset and chronic process. The pain is worse in the later part of the night and the early morning, and also morning stiffness lasts more than 30 minutes. It can be relieved with exercise or activity and worsened with rest. The most commonly affected joints are the shoulders, hips, and knees after the spine, and enthesitis can also be seen. Patients with ankylosing spondylitis may have extraarticular comorbidities such as anterior uveitis, inflammatory bowel disease, psoriasis skin lesions, and so on. The goals of management of patients with ankylosing spondylitis are symptom relief, maintenance of function, prevention of spinal disease complications, and minimization of extraspinal and extraarticular comorbidities. So the treatment includes a comprehensive rehabilitation program, medication, and surgery. In ankylosing spondylitis patients whose joints are destroyed, total joint replacement may be necessary. Sometimes wedge osteotomy or fusion of the atlantoaxial joint are required. In the pharmacotherapy of ankylosing spondylitis, NSAIDs should be used for the initial therapy. Continuous NSAID usage is suggested for patients who have ankylosing spondylitis with persistent active symptoms to lower the rate of radiographic progression in the spine. NSAIDs can be supplemented with a simple analgesics or low-potency opioids such as tramadol or codeine. For patients with axial disease who are not responsive to NSAIDs, a tumor necrosis factor inhibitor is recommended. TNF inhibitors are very effective for symptom relief, can stop bone destruction, and they may have potential for disease modification. Interleukin-17 inhibitor, a fully human monoclonal antibody, secukinumab, that targets interleukin-17A, has recently been found to be effective in relieving symptoms of ankylosing spondylitis. For ankylosing spondylitis patients with predominantly peripheral arthritis who are not responsive to NSAIDs and for whom TNF inhibitors are unsuitable, local corticosteroid injections may be indicated for persistent peripheral arthritis, sacroiliitis pain, or enthesitis. They should not be used at sites of the HLS, patellar, and quadriceps tendons because they may cause tendon rupture. Short-term use of systemic corticosteroids may be helpful for symptomatic control, but we should avoid for long-term use. As a conclusion, patient education and self-management are essential in the treatment of rheumatic diseases. Each patient requires an individualized treatment plan or personalized treatment plan. The physician should have a comprehensive knowledge about the side effects of the drugs and drug interactions before planning medicine. Pharmacotherapy should be monitored at regular intervals. The patient using E.M.R.S.S should know where and when to go in case of a problem, because we know that compliance with treatment is essential for E.M.R.S.S therapy, for the success of E.M.R.S.S therapy. For further reading, you can find these references, and thank you for your attention.
Thank you very much, Professor Akutz, for this very complete and exhaustive presentation on a topic. Also, this one should require more and more time to be fully described, but I think that anyway you gave a very informative picture of what are the main aspects of the treatment. Now we turn into the interventional treatment in two conditions: for neurological problems and for rheumatic and degenerative diseases. We have two presentations of the same speaker, so I will present him once to save time. I am very happy to have with us Levent Orkazar from the Hacettepe University Medical School, Department of Physical and Rehabilitation Medicine in Ankara, Turkey. Levent, it's a pleasure to listen to you, and please, the floor is yours. Thank you very much.
Thank you, Paolo. You hear me well?
Yes, perfectly. Yeah.
Okay. So good evening to everyone. Buonasera. I would like to start my presentation by thanking Professors Cirillo and Boldrini and the rest of the executive committee. Grazie tanto, Cirillo. For two reasons, actually. One, for having been successfully organized this nice and challenging event, despite all the crazy things of the pandemics. I see that we have more than 200 people. And for the second reason, this group is actually the group that I like to lecture the most, because they are youngsters, they are residents, and they are ready to understand everything, and they are waiting for many suggestions, and they have really high expectations. And I know from the past, when I was young, we had the same questions in mind. They still do not have well-established PRM identity. They are still trying to develop their identity, and they have questions like, okay, we are not physiotherapists, but are we pain physicians? Are we rheumatologists? Are we, okay, we are not orthopedic surgeons, but what is the difference between a sports physician and a physiatrist? So, I mean, they have these identity problems still, and we have to help these private Ryans and save these Ryans before this identity problem might turn into a personality disorder, in quotations. So I really like to lecture these young people. And don't forget, we are treating pain, we are improving the function, and in a holistic way, we are increasing the quality of life of our patients. And be sure that you are the best musculoskeletal physicians in the medical society Of course, with ultrasound, and without ultrasound, I cannot promise you. No promises. So this was a recent paper we published in Lancet. We need to further the rehabilitation, and this is actually possible with ultrasound. And for further reading regarding the awareness on ultrasound, why we should do ultrasound, I do not say why we could do or would do, we should do ultrasound. You are welcome to read this paper we published some years ago. And if you have accounts in the social media, please join us in the social media. And okay, and to give the message, straightforward message in the beginning, I would like to say that we have two different lives, before ultrasound and after ultrasound. And we are not speaking the same language if you start using ultrasound. If you're not using ultrasound, we are speaking a different language. So this is my straightforward message. And as you can understand, the rest of my presentation will be sort of brainwashing in favor of ultrasound. And we will be talking about interventions. And my title is from Ankara. I'm coming from Turkey. I'm Levent Özçakar, and I will try to take you through a discussion on interventional things. And I will touch upon awareness and philosophy of the behind this interventional ultrasound. And I will try to give you some exemplary cases from our own clinical conditions. And I will not be talking about technical details or injectates, how we prepare those, why we prefer that one or this one. I will not go into technical things, and I will not touch upon diagnostics. And this is actually the initial motto we have in musculoskeletal ultrasound. Seeing is believing. And the second rule is, if you see, simply you can have access to it. So in any type of intervention that you plan in your clinical practice, just try to understand or just try to recall, can I see the structure or pathology? Yes. Okay, no question, I can have access to it. So easy. But ultrasound can tell you further about having access to it. I mean, reaching precisely the target is not the problem, but we have other issues that we need to discuss in this imaging and guidance philosophy. So it's something like this, actually. When you're not using ultrasound, or when you're not using any sort of imaging, you're something like doing blindfolded archery, and you never know what you're missing, what you're hitting, and what you're injuring or endangering. So you are just, throwing something. It's just like sending love to space, and it does not come back usually. So what you think blindfolded archery is the equivalent of doing blind injections in musculoskeletal practice. And actually, it's not just the precise targeting, but it also helps you in the clinical decision-making in advance, before the intervention. So we try to name it as ultrasound guides the intervention. It's not just ultrasound-guided simple intervention. Ultrasound guides the intervention. So it tells you whether to go, whether not to go, where to go, how to go, and what to inject, or how to inject. So it tells you many things regarding the clinical decision-making process as well. So it helps you confirm the diagnosis. It definitely narrows the differential diagnosis. It might refrain you from the injection. Sometimes you decide not to inject at all, or it might help you technically modify what you're injecting. No discussion about its precise guidance. And if you're sending the patient to surgery with or without intervention, it might also navigate the surgeon, and we call it actually virtual dissection. We sometimes make offensive jokes about orthopedic surgeons saying that you cut and see. Of course, you perfectly see, but we don't cut and still see. And sometimes we see further than a surgeon, because a healthy tendon or a nerve is never cut to see what is inside. But when I put the probe, I can see inside a healthy nerve or a tendon if there is an aberrant structure, which is called virtual dissection. And because of different reasons of convenience, you can do a close follow-up, different timings and different scenarios. At the end, eventually, you have a better comfort and quality that you provide as medical service to your patients. So some years ago, we published this paper saying that sometimes also a little intriguing and offensive or attractive title. We said, are you still doing blind injections, and do you still think they are ethical? And what we discussed was actually the clinical decision-making process. We gave 3 patients as examples. So this was one of them, who was sent for a Baker cyst to be drained. But once you put the probe, you see that it is the aneurysm of the vein and the popliteal artery as well. So in this patient, ultrasound will tell you don't touch the patient, even not discuss the details how to drain it. This is not a Baker cyst at all, so don't touch the patient. This was the first example. So it can tell you whether to touch or not. The second was this one, the decurvain tenosynovitis. As you can see, there is tenosynovitis, but when you go back and forth, you see that there is also a rupture inside the tendon. So even though you go inside the sheath, outside the tendon, and you put steroids, because of the rupture, your steroid will go inside the tendon. So it would be eventually an intratendinous glucocorticoid injection, which is like a scandal for this patient. So it tells you, in the second example, it tells you don't put steroids, but you can go with, let's say, PRP. So in this patient, we change the injectate. So it tells you what to inject. And the third patient, I didn't put it here, but it was an example of subdeltoid bursitis, and the fluid was on the anterior side. And I actually told the physician who sent me the patient, shall I drain it when I diagnosed it? She said, no, I can do it blindly from the lateral side. But I said, the fluid is not on the lateral side. So you will end up with a dry tap, and you will not be able to drain anything. But on the other hand, if you go from the anterior side with a short needle, you will be draining much fluid. So it tells you whether to go inside or not. It tells you how to go inside, where to go, and what to report, okay? So this is the clinical decision-making side. And I will give examples for precise targeting as well. So in short, we say scan, see, and inject, and you don't need to palpate, imagine, or narrate. You don't need to tell stories. And sometimes, again, we want to be intentionally a little offensive, and we say, why do you still draw tattoos on your patients? Don't touch your patients. Just see, scan, and go inside, and you will end up with a prompt diagnosis, prompt injection, and prompt outcome. We are rehab physicians, so we also have sort of biofeedback in our rehab side. So we wanted to prove with this study that you can use ultrasound, interventional ultrasound, as a sort of visual feedback, and we called it sonofeedback. The editor of the journal actually asked, is this a common term that is used? We said, no, it's the first time we said, because this is a new phrase that you can name it with ultrasound, so we call it sonofeedback. In short, when you share the images or the videos on the screen to your patients, because it's so patient-friendly, you change the treatment outcome, of course, psychologically, but you say, here's your pathology, here's my needle, here's how I can drain it, and now you go. Did you have a decreased pain? A perfect reassurance for the patient, okay? So we suggest that you can use ultrasound, definitely changing the treatment outcome, but also as a sort of feedback. Biofeedback, in this case, sonofeedback. And this is the summary of the technique, actually, which I will not go into detail. We have the direct method, which you see the live needle going inside, could be in plane and the long axis on the short axis, or you can do an indirect method sometimes where you do not have access in a good hygienic environment and you want to avoid consequences and so on and so on. You can do an indirect method. And these are the schematic drawings how you can do these. The titles of my two presentations are actually based on the name of the diseases, but I will summarize them, I will gather them, and I will try to give examples regarding the anatomical region. So I will start with the cranial region, and I will end up with the toes. So a cranial, caudal direction, I will give examples of different cases. Sometimes extreme scenarios, but sometimes very common pathologies that we would like to intervene in each every day in our clinical practice. So we start with the head, cranium. What do we inject in the head? We can inject the sutures. This is actually is a novel technique, how you can use ultrasound guidance for targeting the sutures. So here you see the video as a direct in-plane technique. You see the needle approaching the cranial sutures, and here's how you give the botulinum toxin. I don't go into details, but this is not just blocking the muscle. We are blocking the sensory nerve endings that are going outside the sutures that are eventually going to the trigeminal ganglion, and which is actually the pivotal mechanism of the chronic migraine patients. So you can target the sutures and you can give the botulinum toxin by targeting the sutures, not inside the muscles. And there are blind techniques for chronic migraine injections in these patients where you have many, many complications like eyelid drop and other muscular atrophies and so on. Another extreme scenario is overfascial pain. Perhaps you're not commonly facing this problem, but if you're dealing with overfascial pain, targeting the pterygoid muscles, you can definitely medial or lateral pterygoid muscles can be scanned and can be accessed using ultrasound guidance. Or the trigeminal ganglion block or the nerve block, again possible. Always remember, if you would like to have access to a certain structure, just think about it. Can I see it? If I can see it, that means I can have access to it. And to answer the question, can I see it? You have to answer whether is it inside the bone or outside the bone. If it's outside the bone, you cannot miss it, okay? So another extreme example would be GUN, is the greater auricular nerve entrapment. If you're interested, you can target it because you can simply see it. Neck injections are also commonplace in musculoskeletal practice for different pathologies. And just to give you an idea how crowded this region is and how nicely the ultrasonographic corresponding image would be here. Now, when we started practicing these injections, you see the stellate ganglion here. So this is also a window that we approach the stellate ganglion, and you see the fibers of the brachial plexus over here. And you see different muscles and the thyroid and the great vessels. When we shared this with anesthesiologists or pain physicians, they said they started regretting their use, how they dare to do these injections blindly in the past. You see, to reach the stellate ganglion blindly, how will you go? Unless you provide this type of optimal and precise targeting, it's really a scandal, and you never know what you're missing or injuring in those patients. And additionally, I would like to say that these injections, if you do not use ultrasound, are done by CT or fluoroscopy guidance, where you just see this white line. But the targets are all above, overlying, and the white line is the only thing as a landmark you can find in CT or in fluoroscopy. We also discussed this with pain physician colleagues, and we say, how you dare to do these, just seeing this white line, and just try to imagine where the short tissues are. For the nerve roots, the same. You can do many types of injections for the nerve roots. This is one of the guides that we published, so you're welcome to read it. For the neck muscles as well, if you're dealing with dystonia, this is actually the only guideline in the literature where the innervation zones are targeting and where ultrasound guidance is mapped and in details explained how to reach each and every small muscles in the neck, like this one, for instance. So I don't go into details, but this is quite easy and quite simple when using ultrasound. Now, blind injecting people or neurologists sometimes do this with electrophysiology guidance. Okay, you can combine both, but you never be sure in which muscle you are when you're getting the discharge. You get the discharge, you know that muscle is dystonic, but you do not know which muscle is that one. And when you push the toxin inside, you cannot be sure that the toxin is distributed just inside that particular muscle, but not next to it. So this is a nice example of a simple injection where you use the botulinum toxin to distribute it equally in the innervation zone. So you see the in-plane technique where the needle is going throughout the innervation zone. And then when you reach the end, it is not just simply injecting the toxin within the bulky area, because that might not correspond to the innervation zone, and it could not be a cost-effective injection. With innervation zone targeting, which I will show in the coming slides, you can make a cost-effective injection with less dose of toxin and more convenient injections and with more precise targeting. You see how we distribute by seeding the toxin throughout the innervation zone, in this case, the sternocleidomastoid muscle. And this is the two needle guidance, and you see the difference. This needle is the EMG needle. So we also suggest that you insert the EMG needle under ultrasound guidance and be 100% sure where you take the discharge, the pathological discharge, and afterwards block by botulinum toxin. And axillary blocks, if you're interested, you can do with ultrasound guidance, no discussion. Some simple injections, like for myofascial pain or fibromyalgia patients, you might think that these are gross muscles, so I can easily go blindly, but sometimes there are major vessels just passing nearby the area. So you don't lose anything if you scan in advance to check where the environment is and what risky structures that reside or that muscle harbors inside it, in order not to touch them or in order not to produce collateral damage. So even for simple injections, you can use ultrasound guidance just to be sure in advance. For different injections, ultrasound provides you detailed extra techniques. And in the past, I remember we were talking about shoulder injection, but at the moment, shoulder injection alone does not make sense. It doesn't mean anything, shoulder injection. Are you injecting inside the joint, inside the bursa, inside the tendon? Are you giving steroids? Are you pushing the capsule? Are you going next to the bone? What is your exact pathology? Which exact target are you trying to reach? And what exact injector are you putting inside? So you have to answer these 3 questions before each and every injection to be prompt and to be precise and to have a nice clinical decision making. And for different structures, like in this case, you can target the bursa and you can do these dynamically. And you can understand how the fluid is distributed inside the bursa and how you perhaps hydrodissect certain entrapment sites of the capsule, of the bursal layers, or any type of nerve entrapment. This is an example of a partial tear rotator cuff rupture. You see the in-plane technique, and I'm trying to give the fluid, in this case PRP, just next to the tendon. You see the partial thickness, incomplete tear, peritendinous injection. So you have to additionally put explanations inside your injection technique. No more a shoulder injection. That does not make sense. This one is inside the bursa, outside the tendon, steroid injection for chronic bursitis. This one, you see the calcification. So it's a double needle technique. It's a long video, so I will not show all the video. You can go with one needle, hitting the calcium deposits, sometimes trying to aspirate them in the acute phase, and you go with the second needle, then you can do a barbotage or lavage. And I mean, ultrasound can provide you anything. You, as the clinician, has to decide what type of technique you should use. And again, for that decision-making, ultrasound can aid you perfectly. Suprascapular nerve block, again, you see the needle going inside, and here's the nerve, and just around the nerve, you are doing a perineural steroid or local anesthetic injection, depending on the need of the patient after the physical examination. By the way, we are not radiologists. So we are not just doing, oh, there is a shoulder pain, let me do ultrasound. We do not do it like this. We listen to the patient, he's our patient. So we take the medical history, we physically examine the patient, and then only we do a physical ultrasonographic examination. So it's the complete format of physical examination, and that's actually the reason why we call it ultrasonographic examination, not imaging. The discussion mainly pertains to, okay, it's precise guidance, but does it change the treatment outcome? Yes, it does. I've shown you, even with sonofeedback, you can change the treatment outcome, but with precise targeting and with different techniques and with different terminologies, you're changing the treatment outcome. Don't forget, we are not speaking the same language. I mean, you are not talking about the outcome of a shoulder injection. You're talking about precise injections with different types. So in this case, standard or dual target subacromial injections, which is even not possible, not applicable to be discussed with blind techniques. You can also have new techniques like going through the rotator interval, which is like a legend for a blind injected people. Where is the rotator cuff interval? You cannot palpate the rotator cuff interval, and you cannot be sure that you are inside it. But with ultrasound, and if you want, you can go through the interval to dilate the joint if you need for that patient. There are different types of injections, like botulinum toxin injections for different types of chronic pain. I don't go into details, but just to give you an idea, we have data. So now we have data. It's not just saying that, oh, our patient get benefit out of this and they quite improve out of the injection. You have to produce the data. So another rule in ultrasound is if you see, you believe. But if you see, you can quantify, and actually you should quantify, and you should produce data. And for the next generations, they have to use in the same way. For spasticity, for other than muscle injections, we have also very cost-effective and inexpensive phenol or alcohol blocks. And the problem with those blocks is actually the sensory dysesthesias, okay? But with this technique, we have shown that you can specifically target the motor branches. This was just a study of the muscular cutaneous nerve. I don't go into details, but you can target the motor branches going to different individual muscles. And if you block them distally, you don't have these aesthetic complaints of the patients as complications. So there will be no problems. Again, targeting the anconeus muscle, I mean, not possible, not applicable for a blind injecting person. If you want, if you need, you can target it. And if you would like to reach that part of the elbow joint, it is not just one type of elbow joint injection. You can reach many parts of the joint. And depending on what you see in ultrasound in advance, you have to decide where to go, what to inject, and how to inject. This is another example in a rheumatoid arthritis patient where there was the cyst. You see the cyst and compressing the posterior interosseous nerve. So you can drain the cyst, or you can go inside the cyst and give some steroid injections for trying to decrease the size of the wrist. And you see just next to the posterior interosseous nerve how the vessel is pulsating. So if you do this blindly in a rheumatoid arthritis patient, you may really end up with different eventualities which you would never want to. Different anatomic descriptions, another parenthesis. Good ultrasound imaging definitely requires good anatomy. And the vice versa is also correct. When you do good ultrasound, then you can have also better insight into better understanding the anatomy. So this is actually has been started to use in medical students to teach anatomy, ultrasound images for three-dimensional anatomical education. So it's vice versa, but you have to remember the anatomy where you're inserting the needle and which structures you're targeting. So this is a simple example of a decurvane tenosynovitis injection. You see the abductor pollicis longus and the extensor pollicis brevis in the first extensor compartment. And my insulin injector is going inside the sheath and outside the tendon. According to my physical examination and ultrasound examination, I want to do a steroid injection inside the sheath, outside the tendon because of tenosynovitis. And you see how nicely the steroid is distributed. But it's not always the same and not that simple decurvane tenosynovitis in each and every patient. So you might have different compartmentalizations in the first extensor compartment where if you do a blind injection, the patient will not get benefit. So this was a scenario like that one, 2 times injected blindly, no benefit, but the ultrasound guided injection with the outplane technique, because of the septae and because of different targeting, the patient got improved. So you cannot say that this patient does not get benefit out of steroid injection. You have to say that your blind technique does not suffice to improve the clinical scenario of the patient. So here's an example of how different compartmentalization can exist in the first extensor area. So this is the small tendon and this is the APL. You see how many slits and how many septi. So where are you going to inject? You cannot do this blindly, okay? You have to be sure what type of different aberrations exist. Or you can talk in details about different extensor tenosynovitis, like intersection syndrome. You know, sometimes when you say intersection syndrome, oh, very nice diagnosis. But we can talk much more about it. Is it the distal intersection or is it the proximal intersection? So this was a patient with, you see, the second and the third compartments when they were passing over them. So it was here where the compression was more. So where the tenosynovitis existed. So you never inject where you palpate and most painful. Sometimes it's not the case. So again, do ultrasound and decide accordingly. Carpal metacarpal phalangeal joint osteoarthritis, again, can I see it? Yes. So I can nicely inject it, no problem. Here you see my small needle going inside next to the osteophytes and next to the capsule within the degenerated joint. And this is quite impossible if you do not use ultrasound guidance. A typical carpal tunnel syndrome injection. Now, when I say a typical, this is commonly done beneath the retinaculum. But in certain cases with carpal tunnel syndrome, where the underlying pathology would be different, like rheumatoid arthritis or ganglion cysts or anatomical aberrations, you have to target different areas. So are you injecting just beneath the retinaculum? In this case, you see, beneath the retinaculum, I'm pushing the median nerve. So this is a beneath the retinaculum perineural injection. But in another carpal tunnel syndrome patient, depending on the pathology, I might prefer to go next to the tendons. I might prefer to go proximal, or I might prefer to go distal. So ultrasound will tell you where to inject, okay? So never think that, okay, this is carpal tunnel syndrome, the EMG says a carpal tunnel, I should inject it. Where? You never know. And perhaps it's not something to be injected. There is an aberrant muscle, and perhaps the patient needs surgery, even you don't touch the patient. So don't forget, even simple carpal tunnel syndrome injection might not be always the same in each and every patient. Do we have data? Does it change the treatment outcome? Here it is. It does. It was one of the finishing pieces of one of our residents. So we did the PRP injection in carpal tunnel syndrome, and the results are favorable. We do have data, and it does change the treatment outcome. And also, we have meta-analysis for like dextrose or regenerative injections in terms of carpal tunnel syndrome. We do have data, and these show that they are effective, ultrasound-guided injections. And you can use different techniques like hydrodissection. With blind technique, you never can talk about hydrodissection. I mean, what are you dissecting from which structure to which structure? It's like, you know, I just mentioned sending low messages. But in ultrasound guidance, you can precisely do these hydrodissection techniques as well. This is just a simple injection of the first metacarpal phalangeal joint injection in a JIA patient, juvenile idiopathic arthritis, where the tendon is avoided, so I go distal. I cannot inject because there is the tendon here, but this space can be reached from the side if you would like to use the in-plane technique, so you go from the side. You are free. No one can stop you. I can go from the side, I can go from the distal, so long as I have my precise target and so long as I have my prompt diagnosis, no one can interfere. I'm in the right direction. Pulley injections. Usually people say that, okay, I go and palpate the A1 pulley and I inject it. How do you know that the problem is in the A1 pulley? It is perhaps the most common area, but it's not always in the A1. So this is a simple injection of the A1 pulley with the insulin injector, just deep to the pulley, but outside the tendon, because this is a steroid injection. You can have also modified techniques. You can describe modified techniques. So this is what we have described, that you go from the interdigital zone, making it more comfortable for the patient. You have to also care for the comfort of the patient, not just precise targeting, but also comfort. And this is, again, an example of holistically how you increase the quality of life of your patients, even during the interventions. Neuralgia epileptica, no discussion. I mean, I can see the enlarged nerve, so here's my needle, I can go inside it. I can go deep to it, I can go beneath the inguinal ligament, I can go next to it, I can try to dissect the nerve from the spine. This depends on my ultrasound findings and my clinical examination, okay? Cluneal nerves, not just the neuralgia in the lateral femoral cutaneous nerve, but the superior cluneal nerves. And there are specific tunnels that you can name, you can image, you can scan, and you can precisely target. Otherwise, you just palpate and you just try to tell stories about it. Another paper that you can read for hip injections, and this is just an example of a hip injection, classical hip injection in an osteoarthritis patient. You see the deteriorated femoral head with some synovial hypertrophy. This is the capsule. Here's my needle. With the spinal needle, I go inside it, and I just 100% being sure I injected just deep to the capsule and being inside the joint. And this is an example of hyaluronic acid injection, for instance. Piriformis injection, again, I don't know how they do it blindly and how courage, what type of courage they have just going next to the sciatic nerve without seeing it. Incredible. And but nicely you can, this is the gluteus maximus, this is the fat, and this is my piriformis muscle. And if you go with the needle deep to it, you see that this is an example of persistent pain after different injections, which did not subside, but we tried to do a botulinum toxin injection. Here you see the distribution of the toxin inside the muscle. So here's the needle coming, and here's the injectate. Okay, you're 100% sure. You go back home and sleep comfortably and putting your head on the pillow in a comfortable way. And you never see nightmares thinking that did I injure the sciatic nerve, and will this patient come next week with a wheelchair to me in my clinical practice? So this is something that we try to re-summarize it in another paper, writing a sort of a rebuttal to a published paper in the Turkish journal, and we try to explain how you can precisely do it. Sacroiliac injection, again, in inflammatory conditions or mechanical conditions, you can do it in a different way. So this is an inflammatory patient where you go to the distal zone, distal 1/3 of the joint. But if you have biomechanical problems, you have to go to the 2/3 proximal of the joint. This is an injection of the distal part. Coccyx injections, so easy. You palpate, and there is also something called sonopalpation. So you go with the probe on the patient, and as the patient says, this is the painful area, that means you're 100% sure, and you do not have a better sensitive and specific method, examination method, when you compare with this, and you can inject that zone in the coccyx as well. And this is a partial tear of the quadriceps muscle, where there is a very small area, and a PRP injection should be really 100% inside it. Here's my needle, and I go and inject it. No discussion, and it's so simple. In the title, there was also a phrase called regenerative injections. You can do many regenerative injections using ultrasound guidance, but you can use ultrasound guidance also to get the bone marrow cells, to get the regenerative injectate. So using the fat aspiration from the abdominal fat using ultrasound guidance, or the bone marrow aspiration from the iliac wing, you can do regenerative, or you can prepare the regenerative injections using ultrasound guidance as well. I skip these. These are detailed techniques. You can describe meniscal injections with 3-step protocols or with different protocols depending on the pathology and the target you would like to reach. Patellar tendon injections, I mean, so simple. It's like elementary school level. So you can go from the side or you can go from the distal proximal zones depending on which technique you would like to prefer. And this is the follow-up of how the patellar tendons heal. MCL injections, medial collateral ligament injections. Here's the swollen, intact, but swollen medial collateral ligament, inside which I prefer to inject with PRP. So this is a precise targeting, and you go inside it. Iliotibial band injections, again, swollen iliotibial band, and my needle is here. I do a peritendinous steroid injection. I never want to go inside it. So you're just 100% sure. Give the steroid, and you see that the tendon will bend, and you're 100% sure outside the tendon, but just next to it. So it's a precise targeting with optimal injecting technique. You see how the fluid is distributed next to the tendon. Again, detailed pain interventions. Like you can block the genicular nerves for different types of reasons, including osteoarthritis. I don't go into details. Peroneal nerve injections. This is the swollen peroneal nerve. I skip it. Amputee injections, diagnostically, and also for the blocking of the neuroma or for the residual pain of the extremity. You can do different types of injections. Sometimes you might have complications, like we call it the sonopalpation might become sono explosion. So the Baker cyst was quite ruptured. But again, it's under your control. So you follow the fluid and you can aspirate it during the same procedure. Tennis leg injection, again, a PRP next to the myotendinous junction. I'm just trying to summarize in the last 1 or 2 minutes. The ligament injections, this is hyaluronic acid injection for the ATFR, for the ankle sprain. So you can go next to the ligament and you can do an outplane technique and hyaluronic acid injection. Again, this is your decision. You have to be going to give hyaluronic acid, and this is how I'll and from prompt injection. Achilles tendon injection, this is a very nice example. This is a chronic partial tears with a swollen Achilles tendon. I go next to the tendon. I go inside the paratenon. I go inside the ruptured tendon. Normally, in a healthy tendon, you are never able to distribute this much fluid inside the tendon. But once you insert it, once you start getting the fluid, you follow how it's nicely distributed next to the paratenon. Again, you follow it, and you're 100% sure that you're nicely distributed. Fascia injections, plantar fascia injections, the discussion is, where to inject. Is it below the fascia or deep to the fascia? I don't go into details, but our preliminary study says if you go deep, although it's more painful, it's less comfortable, the deep fibers of the fascia are much more likely to be affected. So that's perhaps the speculative reason why the deep injections might help the patients improve complaints in a better way. So you can do motor neuroma diagnostically. You see with the dynamic examination during the nodal sign, how the neuroma jumps out, and then you block that neuroma. If you ask blind injecting people how they do it, they say that we are trying to reach multiple spaces, again, without being aware where is the neuroma. Example of diaphragm scanning or injecting with the EMG needle in a different way. Do we have any disadvantages? Simply no. Sometimes patients are terrified, so you might avoid, but otherwise, this is our needle, and this is blind injecting people's needles. So trying to touch different landmarks and doing, in the past, all techniques, and it's still not comparable. And for the botulinum toxin injections, I refer you to 3 papers you can read for details, because innervation zone targeting using anatomical, histological studies, and ultrasound is perfect. And this is how we describe in our guides, in the Euromuscular's USPRM guides. You can check these papers for the upper limb and the lower limb, and you can check also the guide for the brachial plexus or the low back region for the whole spinal injections in this paper. So I finish with referring to chapter 18 in the first book, different pathologies in the second book, and also the imaging and guidance in the red book, in the third book, if you are interested and if you would like to follow. Definitely see before, not necessarily during the injection. Inject where and however you see best, and try to follow the treatment outcomes, whether it changes or not. Don't forget, this is your eye still, and this is really valuable in your practice. Keep it in a very comfortable place, and never forget about using ultrasound, and try to find ultrasound and get the education. And this is how I finish. Usually this is our life before ultrasound, all dark. When ultrasound entered our lives, we started seeing things and everything bright, became bright. And then, of course, if you're doing ultrasound, as I mentioned in the beginning, you produce miracles and you're definitely superior. Thank you for your attention, and you're welcome. And perhaps you have to join us next month in the Pandemicus, which is in an online platform, and which a different technology congress in the new era. And I would like to thank all of you once again, and see you in person as soon as possible.
Thank you very much, Levent. We appreciated your commitment in pushing towards the use of ultrasound. You know very well how much you are involved in this area, of course, and thank you very much again. And now it will be the turn of Uli Traeger, but I don't see him in the panel. Perhaps something
Paolo,
happened.
I can go on lecturing on ultrasound.
Yeah. Thank you. So let me see. No, I don't see Uli connected. So the proposal is to go to the next speech, which will be presented by 3 colleagues from Malta: Stephen Zammit, Marise Gauci, and E.M.R.S.S from the center of the Karen Greek Center in Malta. I don't know how Stephen will arrange for the presentation. Please take the floor, Stephen, and explain us what's going on. Thank you very much for coming.
Thank you. Buonasera, good evening. First of all, I'm very happy that as our hospital is participating again in the school, this time through this webinar. Obviously, it would have been much better had we been present in Syracuse. Excellent food, we miss it. But we are making the most out of it, and the positive result is that participation is bigger than normal. So together with my 2 colleagues presenting this evening, who are senior pharmacists and various other staff, as you said, we work in our rehabilitation hospital, which has a mixture of adult and geriatric rehabilitation patients. As you know, Malta is very small, just south of Sicily, and therefore we have a lot of outpatient rehab as distances are short. We have a unique clinical pharmacy model in our country, only present in our hospital, and we are very proud of it, where pharmacists are present on the wards and are part of a multi-interdisciplinary team taking care of patients. They are of great help for the doctors with their advice and controls, making patient care much safer from a pharmacological point of view. They control everything every day, the drugs, you know, all the charts, they check about side effects and so on and so forth. So it's very safe to work with them, and it's a big positive thing. Now I will leave it up to them. We have Maryse, she's a PhD graduate in clinical pharmacy who will present managing comorbidities in rehabilitation medicine. And Ian, also a postgraduate and master's graduate, will present his favorite topic about antibiotic stewardship. Thank you for now. Maryse, please, you can start with the first presentation.
Okay, I want to share screen. Okay. Okay, is that okay?
Yeah, okay.
Okay. Okay, so good evening. I'm going to be talking, I'm going to be focusing about the managing of comorbidities in a rehabilitation setting, and I'm going to mainly highlight the clinical pharmacist perspective. So, just a minute. Okay. Oh, wait. Sorry, I'm just trying to move this down. Not managing to advance the slide for some reason. Just a minute. Okay. So when patients are admitted to the hospital for rehabilitation, they may have a number of comorbidities. They can vary. These are some examples. They may have depression, COPD. They may have urinary retention, heart failure. So it is a varied picture, especially if it is the older patient. So the evidence shows that the number of comorbidities, the severity and the type of comorbidity has an impact, a negative impact on rehabilitation. Hence, it is important to prevent the comorbidity if possible and also manage it. So as Dr. Zamita explained, this is Caringbrook Hospital. I'm just giving you a picture to get you into the scene. And this is a rehabilitation hospital. We have 270 patients. At any one time, we have about 1,400 admissions a year. The length of stay varies extensively because we have patients who may have social problems, so they may spend longer time in the hospital. So the median length of stay is 64 days. And the mean age is about 79 years. It's quite an advanced stage, because we tend to, the younger patients are managed more in an outpatient setting, so it's the older patients who stay longer. But what I want to focus on today is that we have an interdisciplinary healthcare team. Now, who are the members of this team? You have the obvious, the ones that would maybe come to mind, the doctor, the nurse, the physiotherapist, the occupational therapist, but there are many members of this team. And today I'm going to highlight the pharmacist's role. Each member of this team is crucial, is very important in ensuring, with their contribution, in having the best optimal outcome for the patient. So we all give a different contribution, but each contribution is important for the overall picture. So this is our team. This is taken on. This was taken on World Pharmacist Day, which is on the 25th of September. And if I focus on those pictures, which are on the poster, I can describe a bit what we do. So in the top left corner, you have the more traditional role of the pharmacist handling medication. But what we do is much more than that. So on the top left, you have the pharmacist on the ward discussing the treatment of the patient on the treatment charts with the doctor and the nurse. In the lower left, we have the pharmacist part of the ward round. So the pharmacist has documentation, has her own documentation, and we are discussing with the doctor and the nurse. The other professionals are not in that picture because here we were showcasing the pharmacist, but during the ward round there will be the whole team. That's why we have an interdisciplinary approach. And finally, in the bottom left, we have the pharmacist explaining to the patient before the patient is going home how to take their medication. We have a chart given to the patient and we go through the treatment with the patient. So we use a systematic approach. We identify the care issue. We have the intervention with the aim of improving outcomes. Okay, and this is documented. So we have a documentation system so that the patient is followed up right through their stay. I'm going to give you now just a few examples of the interventions we make, just for you to get an idea of what the clinical pharmacist intervention is. So, for example, we have a patient with urinary retention and has a catheter, and we observe that the patient has a drug like amitriptyline for neuropathic pain, or perhaps hydroxyzine for insomnia. These have an anticholinergic effect, and so we would advise whether we should actually use an alternative, sometimes even not using the drug at all because we can do without it. Another example is a patient who has hypotension and has come in for rehabilitation after a fracture, and the patient is on a number of drugs for various disease states, all of which can be contributing to that hypotension. Our role there is to assess which is offering the most benefit, so we would deprescribe, we would stop the one which is offering the least benefit for the patient. Another example is a patient, for example, with COPD who has severe dyspnea. This is impairing rehabilitation. We would see their technique, their inhalation technique, and also see if the treatment, assess if the treatment is not subtherapeutic. So then we would recommend a medication review. We have a number of patients with chronic kidney disease, especially in the older patients, so we need a lot of those adjustments. An example is if the patient has digoxin for atrial fibrillation, and then we're going to monitor. We advise on monitoring serum digoxin, various electrolytes to minimize the risk of digoxin toxicity. A further example, we've got a patient with heart failure, has dyspnea, so that again is going to hinder rehabilitation. Bumetanide would have been increased to resolve that pulmonary edema, and our role is to make sure we're monitoring, looking at the electrolytes to make sure that the patient doesn't become hypokalemic with problems of that, hyponatremic with the problems associated with that. So we are preventing, we are being instrumental in adverse drug reaction prevention. My final example is a very important one. We have a number of patients with swallowing difficulties because they have had a stroke and or maybe they have Parkinson's. The patient may actually have an enteral tube. So then we have a problem with medication administration. We discuss with the doctor about to refill the medication. The patient may not need all that medication, or we can change it to be administered less frequently, perhaps. And then we would actually give the instructions regarding administration. Is the tablet to be crushed, dispersed, or do we have to leave a period of time between the feed which the patient is having and the drug administration because of an interaction? So there are a lot of issues associated with this aspect. So those are just a couple of examples about what we do. I'm going to finish my slides and I'll pass on to Ian. These are just a few publications which are highlighting the role of the pharmacist specifically in a rehabilitation setting, and there is very good evidence of a positive impact. So thank you. I'm going to pass on to Ian now, who's going to focus about antibiotic stewardship.
Thank you, Maurice. One moment till I screen share. Is that okay? Is it okay?
Okay,
Yes,
okay.
Okay. Thank you, Maurice. So patients get admitted into a rehab facility for therapy, but sometimes they develop an infection which has to be treated. Now, it is a known fact that antibiotics have contributed approximately 20 years to our life expectancy compared to the pre-antibiotic era, 80 or so years ago. This is a precious resource that has to be preserved. In the words of Sally Davis, who was one of the most influential women in the British National Health Service, if we do not act now, any one of us could go into hospital in 20 years and die because of an ordinary infection that cannot be treated by antibiotics. And this is occurring in a setting where our antibiotic pipeline is drying up. There are much fewer antibiotics coming on the market today than there were, say, have implemented a program, but this should be extended also to rehab facilities. It is also our responsibility. Our program in Caring Rec has been going on for the past 3 years, and the very first only by knowing where we stand can we determine in which direction we should go. And this is where we stand today. The penicillins remain the workhorse of antibiotic therapy within our hospital. And as runners-up, we have the quinolone antibiotics. And probably this is a typical pattern of most European hospitals. It is remarkable that after 80 years in clinical use, the penicillins still remain our top agents. And this is for two very specific reasons. One, they remain to be highly effective agents. And secondly, they are a safe group of antibiotics to use. This cannot be said for the quinolone antibiotics such as ciprofloxacin and levofloxacin. They are coming under increased scrutiny by the European Medicines Authority because of their unfavorable safety profile and as well as their propensity to induce resistance. It is reassuring to see our consumption of quinolone antibiotics coming down. Now, we wanted to relate our consumption with the indication of use, and for this, we carry out point prevalence studies throughout the year. Through such studies, we could collect data not only on the indication for use of our antibiotics, but also for how long do we use these antibiotics and through which routes do we use these antibiotics. And if we have a look at this infographic, which relates to a survey carried out in spring of last year, you will see towards the left bottom end of the slide that 60% of our prescriptions had a stop date documented on the treatment chart. Now, this is very important because if there's no documentation of a stop date, you could have an unintentional prolonged treatment of antibiotics with all its negative implications, such as not only exposing our patient to side effects, but also increased risks of resistance. And we wanted to improve on this. And as an antimicrobial stewardship intervention through our Pharmacy and Therapeutics Committee, we have adopted a policy which now mandates that all prescriptions should have a stop or review day documented on the treatment chart. If we have a look at the bottom right-hand side of the corner, you would see that 50% of our antibiotics during this survey were administered via the IV route. And this highlights one of the shortcomings of point prevalence surveys, in that it just gives you a snapshot of what's going on in the hospital at that time. And this cannot be always extrapolated throughout the year. In fact, we had a look at our hospital pharmacy inventory systems to see actually what is the volume of IV antibiotics going through the hospital. And during 2019, this was more closer to 1/3 of our antibiotics, which were dispensed as IV formulation. But still, there is a lot of scope to change over from IV to PO. It is much safer, not only because you reduce the risks of medication errors, where it is a known fact that there are more serious medication errors with IV antibiotics rather than with PO antibiotics, but you eliminate the risks of inline infection. And after all, it aids rehabilitation, because if you have your patient which is hooked up to an IV line, it is more difficult to ambulate your patient. And at the moment, then again, as an antibiotic stewardship intervention through our pharmacy and therapeutics body, we have an IV to PO policy, which will hopefully be approved in the coming weeks. Now, we also do other interventions, quality interventions throughout the year. And one intervention which we carried out earlier on this year was a focus on antibiotic dosing in patients with renal impairment. And through the survey, we have pinpointed levofloxacin as a potential agent for inappropriate prescribing of as regards dosing in renal impairment. And through this infographic, which we have circulated back to our clinicians as well as clinical pharmacists, we hope to see an improvement in the dosing of this antibiotic. And I would like to conclude here with a final remark, is that by establishing such a program, we have created another platform where we could engage clinicians in discussing medication care issue with clinical pharmacists, and all this for the better outcome of our patients. And I conclude here, and I thank you for your attention.
Thank you both. I just want to conclude our intervention by showing that even in a rehab hospital, where we generally focus on the pathology, whether it's a stroke, it's multiple traumas, Parkinson's, or any other disease, we have to also take care of the comorbidities that patients have, and the pharmacist's intervention to us is very important so that we can control and prevent any other complications while we are treating the patient in rehabilitation. That was the aim of the intervention. And we thank you for giving us this chance to present once again in the school. Thank you.
Thank you, Stefan, and thank you to your colleagues. We are trying to contact Yuli Traeger because he said that he's connected, but something doesn't work anyway. I would suggest to go to the next presentation and to see if Ian will be able to join us. We have the pleasure to host Maria Laura Sollini, a young resident in physical rehabilitation medicine of the Tor Vergata University in Rome. She speaks instead of our colleague Calogero Foti, who is not able to join us tonight. Anyway, I'm sure she will go do an excellent presentation. Her topic is about fibromyalgia, managing the pharmacological treatment. So thank you, Maria Laura, for having joined us, and the floor is yours.
Okay, thank you. Good evening to everyone. So I'm going to talk about fibromyalgia. What is fibromyalgia? Fibromyalgia is a chronic disabling disease of unknown etiology, which main symptom is widespread pain followed by fatigue and lack of sleep. This triad is often associated with cognitive, digestive impairments, often accompanied by anxiety and or depression that have an important influence on quality of life. It is characterized by a chronic widespread musculoskeletal pain with greater than 3-month duration, causing physical and emotional problem, interfering directly in functional capacity and quality of life. Fibromyalgia affects the 2 to 4% of general population, particularly women, about 80%, but also occurs in men and children of all ethnic groups. Diagnosis is usually made between the ages of 20 to 15 years. In recent years, there has been a spike in literature about fibromyalgia, so we can say that it is a recent pathology, which interest has increased over the years. Nevertheless, diagnosis and management remain a challenge. It often takes over 2 years for a diagnosis to be made, with an average of 3.7 consultations with different physicians. There is a delay of approximately 10 years in diagnosis compared with persons who do not have fibromyalgia. Physical and rehabilitation medical doctor has an important role in diagnosis. Thanks to his general vision of the person, he recognized that there isn't only an organic problem, but a complex pathology, as fibromyalgia is. It overlaps substantially with other central sensitivity syndromes, such as chronic fatigue syndrome, irritable bowel syndrome, the post-traumatic stress disorder, and others. And it coexists in high frequency with certain illness characterized by systemic inflammation, such as Crohn's disease, the systemic lupus erythematosus, and others. The prevalence of fibromyalgia has multifactorial explanations, which also refer to different painful experiences of psychological and sociocultural origin, but also to mechanism of neurological amplification and neurological inhibition that have genetic and hormonal support. Fibromyalgia pathophysiologic mechanisms are still unknown. However, there is a widespread dysfunction of the central nervous system, reflecting a likely alteration in the regulation of the pathways of pain, of sleep and cognition, but also of the autonomic nervous system and neuroendocrine pathways involved in stress response. So we can say that we need to talk about a biopsychosocial model of fibromyalgia because there are many variables that influence the pain in this pathology. Fibromyalgia is a diagnosis of exclusion, and patients must be evaluated for the presence of other disorders that could be the cause of symptoms before a diagnosis of fibromyalgia is made. The clinical assessment may reveal objective evidence for a discrete or comorbid illness, such as hypothyroidism, polymyalgia, cardiac condition with chest pain, dyspnea, and palpitation. Another characteristic is that these patients don't have consistent abnormalities on laboratory testing, routine laboratory and imaging studies that can help to rule out disease with similar manifestations. It's important to study the complete blood count, the metabolic panel, the vitamin D level, the vitamin B12 level, the erythrocyte sedimentation rate, and other. But the main symptom of fibromyalgia is pain. Is a persistent of 3 months widespread pain or tenderness on both sides of the body, above and below the waist, including the axial spine. The American College of Rheumatology in 2010 said that for the diagnosis was needed a widespread pain with a score greater than or equal to 7 on any of the 18 anatomical location. So we're saying that tender points are generally used to make a diagnosis. In this slide, we can say which are the tender points that we touch for the diagnosis. But the American College of Rheumatology 2016 revision doesn't talk about tender points, but about regions. In fact, the diagnosis required a generalized pain defined as pain in at least 4 or 5 regions, the left upper, right upper, left lower, right lower, and axial, and they introduce the symptom severity scale. The scale explores fatigue, walking unrefreshed, and cognitive symptoms. For the diagnosis, we can also use some questionnaires. First of all, the fibromyalgia impact questionnaire that quantify the different and the several dimensions of the fibromyalgia, so the functionality, the sleep disorder, the depression, fatigue, stiffness, and other. We can use the VAS scale for the pain, the Bartley index for the disability, and the short form 36 for the quality of life, and the instrumental activities daily living scale. Fibromyalgia is a complex pathology, so it needs a multidisciplinary team for the treatment composed by different healthcare providers. Literature is full of information about the treatment and management of this pathology, and the studies available are of poor quality. The most recent recommendations for managing are published in 2017 by the European League Against Rheumatism that reviewed the most recent studies on fibromyalgia treatment. In this slide, we can see the different pharmacological trials that are studied, and we can see that they are very much the same is for the non-pharmacological therapy and treatment that are tested for this pathology. So, as a result of those studies, Euler did a flow chart for the treatment. It recommends psychological therapy for the depression, the pain-related depression, anxiety, catastrophizing, the pharmacotherapy for the pain and the sleep disturbance, and the rehabilitation programs for the disability. About the pain, pharmacotherapy are recommended paracetamol, tramadol, that is the gold standard, pregabalin, and duloxetina. Non-steroidal anti-inflammatory and acetaminophen are of limited efficacy in reducing pain due to fibromyalgia, but it can be used sometimes for treat the acute pain. For the pain, we can also use mesotherapy, that is a local analgesic treatment with reduced amount of drugs, generally cortisone or anesthetic, directly over the site of the affected structure. So we can take the advantage by the local effect of drug and the effect directly on tender points. For fatigue and sleep problems are recommended duloxetina, amitriptyline, cyclobenzaprine, and muscle relaxants. For the depression and the anxiety, we need a psychiatrist because it's necessary a psychopharmacological treatment and a cognitive behavioral therapy. What about supplements? We know that supplements are generally used in clinical practice, but they aren't recommended by Euler, and there are controversial opinion about them in literature. Studies show good results by treatment with supplements, generally in use with other treatment. So we can say that we can use them. About the non-pharmacological therapy, first of all, the most important for the PMR is the physiotherapy that minimizes pain, fatigue, and muscle tension, improves the level of stress, anxiety, and depression in fibromyalgia patients when performed on a regular basis and under monitorization. Also, stretching exercise are recommended because they allow functional muscle length recovery, providing stress relief, improvement in amplitude, the movement. The physical exercise that induce the activation of brain areas that regulate pain, release endorphin, and increase fatigue resistance by increasing the musculoskeletal metabolism, and the manual therapeutic resource as the massage therapy. At the end, also the Tai Chi Chuan, that is a traditional Chinese martial art, is shown to be useful to increase in healthy people speed of movement, stress, coordination, balance, each over time developing a body-mind exercise able to reduce anxiety, improve mood, quality of sleep, and self-confidence. So, in conclusion, we can say that it is not enough to have a unique approach to treat fibromyalgia, but we have to use a biopsychosocial approach because fibromyalgia is not a muscle or a bone breaking, but it is a person who suffers from a crippling disease. In patients with fibromyalgia, it is demonstrated that a multidisciplinary intervention approach significantly improves the quality of life and performance. So, thank you to everyone for your attention, and have a good evening.
Thank you very much for your presentation, and compliments for your presentation, and greeting to Professor Calogero Foti. And now we are going to the last presentation. We are able to connect with Yuli Treger. Welcome, Yuli.
Thank you.
Yuli Treger, Director of the Rehabilitation Soroka Medical University Center in Beersheba, Israel, and he will talk about stroke, managing the pharmacological treatment. Thank you for joining us, Yuli. The floor is yours.
Can you see it?
Yes, okay.
Can you see my presentation?
We were able to see it, but now not yet. Not anymore.
Now?
Yeah, okay, fine, perfect.
Okay, so thanks to organizers. I am very happy to be here, and I'm sorry that I was late somehow, but connections, it was some problem. Okay, so I would speak about stroke and the pharmacological management of stroke. I think we have some problem with this field because from the one side, there are no real treatments in the rehabilitation field for stroke patients. From the other side, we have patients with a lot of drugs, a lot of pharmacological management. So we must understand how we deal with this duality, I will say. So 20 minutes, it's not enough to speak about all kinds of therapies, but I will try to present some kind of general management of those patients. So when we are speaking about stroke patients, we have, first of all, the acute stage. Indefinitely, it is not our field, it's not a rehabilitation specialist, but it's very important today, and I can say as someone which started my practice 30 years ago, that now we have much easier patients when we have a lot of acute treatments, a lot of medical treatments to in the acute stage. So we in the Soroka Medical Center, we are working together with the neurological department, and I can say that if we see in our department a severe hemispherical stroke, mostly it was out of the time window, and that is the reason that he didn't have thrombolytic treatment in some of the existing ways. When we're looking about the whole panel of stroke medical treatment, generally in rehabilitation, we are dealing mostly with the prevention and treatment of complications. All other things, reperfusion strategies and so on, neurologists are dealing with, and as I told, it's very good for our patients and for our staff. So if I am trying to look on the pharmacological treatment in the post-acute stage in rehabilitation department, rehabilitation program, I can speak about three big parts. First is the prevention of recurrent stroke. Second is the prevention and treatment of complications. And third one is the enhancing brain self-repair and stroke recovery. So generally, I would start from the third one. And the third one, I think it's theoretically maybe most promising one, but practically we have in our everyday practice not no one of them in our department. So we can look on the list, theoretical list of drugs. According to the literature, all drugs have no strong evidence of effectiveness, and all the list goes from up to down, from more evidence to less evidence. As you can see, there are a lot of drugs, serotonergic drugs, dopaminergic drugs, noradrenergic drugs, and so on. As I told, no of them we can use in Israel at this stage in the clinical practice. I wanted to say that young people, young doctors, maybe will work on that, and sometimes we will have such drugs in our arsenal. I was hearing from for other speakers, and I think from this point of view, stroke patient in rehabilitation stage have a small amount of pharmacological help from our doctor staff. The second group is the prevention of recurrent stroke. Generally in Israel, we have no stroke units, so most of patients are coming to our department from neurological department. But the medical treatment of prevention of the next stroke, the secondary prevention, are already more treatments are already in the list. So there are different types of antiplatelet and anticoagulant treatments in ischemic stroke and some other approaches in hemorrhagic strokes. but generally we have some list of medications. Sometimes we go on, sometimes we need more investigation to understand what is the real problem and how to prevent next stroke. And in many cases, we are in touch in different medical staff in the hospital to decide what is the better way to go on with the patient. The second part of prevention, as we know, is a pharmacological management of known risk factors. It's arterial hypertension on the first place, but there are other also. What happens in the rehabilitation department is that a patient has much more time with us. Patient is under our staff supervision, so we can do, let's say, better job than was done in the acute stage. Let's say in our country, in the neurological department, it can be 3, 5, 4 days. So it's not enough time to manage the problem. And one more point, that in the acute stage, every patient is in some kind of stress. So the treatment in the acute stage is different from the go-on treatment after. So there is a huge job of medical staff in the rehabilitation department to balance and to look for the best medical treatment in hypertension. The same issue is diabetes mellitus. As we know, diabetes is also one of the huge risk factors for stroke. So our aim is to discharge the patient from the acute stage with a good balance of diabetes. We know that after they go out the hospital, when are discharged and go to the outpatient management, it is much more difficult to do that. The other problems, as we know, are hypercholesterolemia, some kinds of hypercoagulability disorders, and heart diseases. In all those issues, also we have a different pharmacological approaches to balance the problems. And in our case, we are a department in the General Hospital. We have a lot of medical staff to help us and to think together to give the most appropriate therapy for the patient. I think the important, the biggest, I would say, field of the pharmacological treatment in our case is in the field of prevention of treatment of complications. Here also, of sure, it is impossible to speak in the short presentation about all kinds of complications after stroke, but the most important, I will say a few words. I would put in the first line some kinds of different psychiatric complaints. We see a lot of patients with signs of depressions. In some cases, more in hemorrhage. We can see delirium. Many patients of us have insomnia, anxiety, apathy, and so on. So in most cases, we can deal with our staff without medications. But when we need, the way is to use maybe the regular medications with caution. In our department, we are making the decision with our psychologist and even with psychiatrist to understand if the patient need some kind of psychiatric treatment, pharmacological treatment, and which one. Because the reaction of post-stroke patient is unpredictable in very many cases. So we can sometimes make more harm than help to the patient. So we must start in a very low dosage, and we will go on very slowly to, let's say, as an example, to make a patient sleep good in the night, but in the morning be able to come up and to go on to our active rehabilitation procedures. So there is place for medical treatment, for pharmacological treatment, but with caution and slowly. We have some group of stroke patients which come to our department after epileptic seizures. We must know, we know it, we must take into consideration that most of anti-epileptic drugs have some influence on brain plasticity. So I'm not sure that we are running towards the giving the good anti-epileptic therapy from the first day. Today, in most cases, we are not speaking about medical prophylaxis in ischemic stroke, but where this complication exists, we have no choice, and we are starting to give medications. Also, in our department, we are doing this job together with our neurologists to choose the best medical treatment. I think that I will not speak a lot about management of pain. We have quite a lot types of pain if in post-stroke patients. We can see musculoskeletal pains for overuse. We can see shoulder pain, neuropathic pain, and so on. So we had a very good lecture here about the management of pain. Generally, in stroke patient, management of pain is quite the same as in other groups of patients. So here also we need pain management to help the patient to go on with his rehabilitation program. And in some cases, as a neurogenic pain or shoulder pain, we must think about going on after discharge with management of pain. Most of patients in the first stage have constipation. Also, some feel that sometimes we need combination of laxatives and enema treatment. In some cases, we have from the neurological neurosurgery department already with a big problem. So we need a very intensive treatment, and we need to take this problem into consideration and to check what is happening and what is going on. And the last one that I want to mention, but also I will not go deeply in the issue, we also had a very good lecture about the management of spasticity and management of rigidity in Parkinson patient. We can see both of them, more spasticity and less rigidity, but both of them are in the list of the stroke patient complications, and most of them we must deal with them even in the acute department and after that. I think the most important aim of the medical pharmacological treatment during subacute rehabilitation of stroke patient is to go down with medications. The problem is that most of patients has a long list of pharmacological treatment. I would say there are a few reasons. One of them is that most of them come to the acute, to the neurology department with the list of chronic therapies, of chronic pharmacological treatment, and they are coming in the acute stage in stress, so they have even more pharmacological treatment on the acute stage. So when they come to our department, our aim is to keep them down and to discharge them with the smallest amount of medicines. We must understand that when patients go home to outpatient department, he's already out of medical control, and in many cases it's quite difficult to go on managing it. So I think it's a huge aim of stay of post-stroke patient in rehabilitation department. So thank you for your attention. Good luck and good health in those times for everyone.
Thank you very much, Yuli. And we arrived at the very end of this exciting journey in many important topics related to our specialty of physical medicine and rehabilitation. So I wish to thank all the speakers and all the participants too. We had, for most of the time, more than 200 persons connected following the webinar and the school, and I think it's a good success. And I wish to compliment again Franco Cirillo for his commitment in making this, in organizing, even in such difficult times, such a very interesting and important initiative. I just ask Franco if he wants to speak a while and to give us an arrivederci. I hope so.
No, prima di salutare, la cosa che mi fa un piacere enorme, abbiamo chiuso alle 20:40, esattamente in orario, non un minuto più né un minuto in meno, pazzesco. Eccezionale, veramente. Complimenti a tutti. Allora, thanks to the speakers, to the chairperson Paolo Boldrini, to the Italian Society of Physical and Rehabilitation Medicine, to Guido and Medicaid staff and participants. Good night. I hope that we see next year. Thank you very much. Good night.
Thank you very much, Franco. Have a good night.
Thank you. Good night.
Thank you so much.
Buonasera.
Good night, everyone.
An applause to Franco.
Ciao,
Grazie.
Ciao, Michele.
Ciao.
Ciao.
Ciao.